Please give a standing ovation to our dignitaries. Dignitaries, kindly occupy the seats in the front row. Please take your seats. As our former president, the missile man of India, Dr. APJ Abdul Kalam said, "The purpose of education is to make good human beings with skill and expertise. Enlightened students can be created by teachers." Good morning, ladies and gentlemen, and warm greetings to each and every one of you. On behalf of the Department of Conservative Dentistry and Endodontics, we extend our appreciation for your presence today. It is my pleasure to welcome all of you to the 5th edition of Rotary Endodontic Training Program, ENLITE 2022, Endodontic Learning Initiative to Excel. Endodontics forms the foundation of a successful clinical practice, but the training imparted to dental students during BDS course is not enough for a quality endodontic practice. So, understanding the need of the hour and to bridge this lacunae for fresh graduates and general practitioners, a well-structured 3-module training program has been designed. And we are proud to say Annoor Dental College is the only college which provides rotary endodontic training at undergraduate level. Our commitment for excellence is unwavering, and the facilities offered are unmatched. So without further ado, let us start this today's program with Annoor Anthem. I request all of you to kindly rise and place your right hand over your chest. Standing for 1 minute in remembrance of our founder chairman, late Janab TMC Haji. Thank you. Please take your seats. Annoor Dental College was formed out of the foresight, persistence, and leadership of our founder chairman, late Janab TMC Haji, who was a virtuous visionary hailing from Muvattupuzha. The seed he planted 2 decades ago now stands in full bloom. We Annoorians feel privileged to be a part of this prestigious institution, which offer relentless service to the society and enormous opportunities to students, which was our founder chairman's vision. And it is efficiently being carried out by our board of directors. The journey of Annoor through the years has been an embodiment of vision, hard work, and relentless march towards excellence under the exemplary guidance of our principal, Professor Dr. Jiju George Baby. And miracles do happen when we work together as a team. In 2019, we were awarded the Best College of the Year by the Higher Education Review magazine. In 2020, we were ranked 22nd among the private dental colleges in India by a survey conducted by the Week magazine. In 2021, we were crowned with NAC accreditation. As a research institute, we have 27 Indian Council medical research projects and 16 Kerala state funded projects, and 4 of our students are recipients of the prestigious Tata Trust Scholarship. To cap it all, the prestigious Nelson Mandela Award for the Best CEO was awarded to our director and CEO, Mr. T.S. Binyamin. And the Best Principal Award by the Global Society of Health and Education was awarded to our principal, Professor Dr. Jiju George Baby. So, here we present a small video sharing a few glimpses of Annoor achievements. Now I invite Dr. Josie Matthew, Professor and Head, Department of Conservative Dentistry and Endodontics, for the welcome address.
Respected Principal Dr. Jiju George Baby, guest faculty of the day Dr. Francie Joseph, Vice Principal Dr. Lisa Ma'am, Students Dean Dr. Jose Paul Sir, other HODs, faculty members, colleagues, participants of ENLITE 2022, and dear students. We, the Department of Conservative Dentistry and Endodontics, is extremely proud standing here on the opening session of ENLITE 22. ENLITE, or Endodontic Learning Initiative to Excel, launched in 2018, is being organized for the fifth consecutive year today, and around 150 young graduates have successfully completed this training program on rotary endodontics of posterior teeth till date. We are proud that we could achieve this even during this unprecedented COVID scenario. Let me proceed to the pleasant task of welcoming you all. Any program in Annoor is the brainchild of Dr. Jiju George Baby, our principal. Same with ENLITE also. He was there right with us from the conceptualization stage of ENLITE, leading us. Sir, I take this opportunity to wholeheartedly welcome you to the opening session of 5th edition of ENLITE. Dr. Francie Joseph, our guest speaker of the day. I firmly believe Francie believes in the philosophy, let action speak more than the words. This soft-speaking endodontist, I am sure, is going to surprise you with the beauty of the endodontic cases he is going to present today. Dear Francie, I welcome you to Annoor Dental College. Lisa ma'am, team leader of Conservative Dentistry and Endodontics, I welcome you to this program. Jose Paul sir, our students dean, is always a constant source of inspiration and motivation in any program that we undertake. Sir, I welcome you. Dear participants of ENLITE, this is your day. Make maximum use of this. I welcome you all. Special welcome to the non-Annoorian participants of ENLITE 2022, Dr. Simi Karthedam, Dr. Anna Roy, Dr. Hadia, and Dr. Shaheen. All HODs and faculty members of Annoor Dental College have supported us with their constant motivation and encouragement. I welcome you all to this gathering. I take this opportunity to extend a warm welcome to all PGs, interns, and undergraduate students who have assembled here. Once again, I welcome you all. Thank you.
Thank you, sir. Now I invite our Students Dean, Dr. Jose Paul, Professor and Head, Department of Periodontics, to give us an overview of the program.
Respected principal, guest faculty, vice principal, all teaching staff, delegates who are outside Annoor and also inside, students, dear friends. Now, I hope you know about the overview of this program. It's been there, printed, and it's been distributed. I just want to give you the importance of this program. ഈ നമ്മൾ എൻട്രൻസ് എഴുതിയ ഈ ഫസ്റ്റ് റാങ്കുകാരൊക്കെ ഏത് സബ്ജക്റ്റാ ചൂസ് ചെയ്യാറ്? എൻഡോ അല്ലേ ഓർത്തോ? എന്തുകൊണ്ടാ അത്? ബാക്കി സ്പെഷ്യാലിറ്റി മോശമാണോ? ഓറൽ സർജറി, ഡൈനാമിക്സ് അല്ലേ? വൈ എൻഡോ, വൈ ഓർത്തോ? ഒറ്റ കാരണമുള്ളൂ, ജോർജുട്ടി അല്ലേ? ഇറ്റ്സ് ബിക്കോസ് യു ക്യാൻ മേക്ക് മണി വിത്ത് ഇറ്റ്. ഇപ്പം നമ്മളൊരു ക്ലിനിക്ക് സ്റ്റാർട്ട് ചെയ്ത്, ഇവിടെ ക്ലിനിക്കുള്ളവർ കാണും, പക്ഷെ നമ്മൾ പ്രാക്ടീസിലേക്ക് പോകുമ്പോൾ നമ്മുടെ അടുത്തൊരു പേഷ്യൻ്റ് പെയിനായിട്ട് വന്ന, അതായത് ഡെൻ്റൽ പെയിനായിട്ട് വന്ന, അതിൻ്റെ ഒരു റീസൺ മേ ബി എ പൾപ്പൽ പെയിൻ or it may be a periodontal pain. But mostly it is of pulpal origin. And how are we going to manage this? Nobody wants to extract tooth now. So the only way to manage that is by doing good endodontic treatment. And that is the importance of that. അതിനിപ്പോൾ അതിന് PG എടുക്കണോ വേണ്ടയോ എന്നുള്ളത് it's a debatable topic. There are a number of undergraduates doing very good endodontics. The only thing is that you should know the basics of all these procedures. And these courses way for that. നമ്മൾ ഈ കോഴ്സ് തന്നെ എടുക്കുകയാണെങ്കിൽ anatomy of root canals, instrumentation, disinfection protocols, obturation protocols, അതുപോലെ തന്നെ മാഗ്നിഫിക്കേഷൻ എല്ലാം ഇൻക്ലൂഡ് ചെയ്തിട്ട് പേഷ്യൻറ്റിൽ ചെയ്യാൻ പറ്റുന്ന ഒരു പ്രോട്ടോക്കോളാണ്, ഒരു കോഴ്സാണ് ഡിസൈൻ ചെയ്തിരിക്കുന്നത്. And I would like to congratulate Conservative Department for doing this for the 5th consecutive time. Okay. And I would like to congratulate each one of you for joining this program also. And I understand that we have 45 delegates for this program, and that is really wonderful. Okay. So I hope all of you take part actively, clear all your doubts, and master endodontics with this course. All the best. Thank you.
Thank you, sir. Now we are starting with our lectures. The first lecture is by our eminent guest speaker, Dr. Francie Joseph. And the topic for first session is Hunt for the Hidden, Management of Elusive Root Canals. We have a moderator for this session. I invite Dr. Debu George Matthew, Professor and Head, Department of Oral Pathology, to moderate the session. Now I invite Dr. Jason Paul, Senior Lecturer from the Department of Conservative Dentistry and Endodontics, to introduce the speaker.
Morning, everyone. Isaac Newton once said, "If I have seen farther than anyone, it is because I stood on the shoulder of giants." It is my privilege and honor to introduce before you one such giant in the field of endodontics, Dr. Francie Joseph. His exploits regarding the management of complex root canals are legendary in the endodontic fraternity, and I'm sure you will be inspired to do quality endodontics after his session today. Dr. Francie completed his BDS in 2006 from GDC Kozhikode and went on to complete his MDS from the same college in 2009. He worked as a senior resident in Kottayam Dental College in 2009-2010. And after that, he went on to work as a senior lecturer in Indira Gandhi Institute of Dental Sciences, Kodamangalam in 2010-2011. After which he started his own specialty practice, White Orchid Specialty Dental Care in Muvattupuzha. He is married to Dr. Nima Mariam Francis, who is a specialist in oral radiology, oral medicine and radiology. And they have their own dental diagnostic center, 3D Dental Diagnostics. Today, they have two beautiful daughters, Dia and Disha. And without any further ado, let me welcome Dr. Francie Joseph to the stage to present his lecture. Sir, the stage is yours.
Hello. Good morning, all. First of all, I would like to thank the Department of Conservative Dentistry and Annoor Dental College for giving me such a great opportunity. And my topic is the hunt for the hidden, the management of elusive canals. Elusive canals means the canals that may be missed during the routine root canal treatment. That are the canals that are difficult to negotiate or find. So it may be a little bit difficult if you are a fresher, because next topic is the normal anatomy. In these slides, we will just see the different anatomies, that is the difficult anatomies. So over the past decades, many technologies have evolved to enhance the clinical performance of dentists for start to finish endodontics. And many of these technological breakthroughs, however, are meaningless if a practitioner is unable to identify a specific or revise underlying canal or root canal system. So the aim of my presentation is to help you all to identify the difficult canals, how to identify it, how to locate it. Then with practice and patience over a period of time, you will get to identify these type of anatomies. Missed canals include pulp tissue, bacteria, and other irritants, all of which contribute to clinical complaints and endodontic lesions, ultimately leading to endodontic treatment failure. So according to an in vivo study by Dr. Asar Iqbal in 2014, the factors which were most responsible for endodontic failures are unfilled canals, unfilled and missed canals, and untreated root canals. So hence it is paramount importance that we hunt for those hidden canals and clean, shape, and fill them for the positive treatment outcomes. So my aim is to share some clinical tips in identifying, locating, and managing the common anatomical variations of the root canals. So first, the strategies for locating the canals. First is knowledge of the tooth anatomy. You should all have a thorough knowledge of the normal anatomy, what all variants will be there, how to identify them. Then radiographic diagnosis. First one is 2D radiograph, a good preoperative radiograph, and reading a good radiograph will give a lot of information about the root canal anatomy. Then in difficult cases, you can use the help of cone beam CT. Then enhanced vision with enhanced magnification and illumination are very helpful in locating hidden anatomies. Then sometimes according to the different anatomy, you have to slightly modify your access cavity. Rather than the normal design, sometimes you have to modify the access cavity. Then ultrasonics. Ultrasonics is very helpful because it will help in precisely drilling the or modifying the access cavity to locate the hidden canals. Then there are some tests used for canal location. We'll discuss that in the following slides. So basically, tooth anatomy is like fingerprints. Basically, when you are looking from a macro view, or many tooth may have similar anatomy or morphological characteristics. But when you are going into the closer looks, it is like fingerprints. Every tooth is different. Every tooth anatomy is different. So when you are doing a root canal, always expect the unexpected. So I will show some good pictures, clearing technique that has been demonstrated by Muvattupuzha. This is a mandibular second molar with 3 mesial canals. Usually mandibular molar, you know that there will be 2 roots and there may be 3 or 4 canals. But in some cases, in mesial canals, you can see it cannot be called as an entire canal. It is like a root canal system, mesial root canal system you can call. So 3 mesial canals with separate portal of exit. Here also mandibular premolars, which are called endodontic enigma, which are notorious for anatomical variations. Usually we may see that, we'll feel that the mandibular premolars are very easy to treat. But lot of root canals failures occurs with these type of anatomies because it is one of the tooth that is having lot of anatomical variations. So in the first picture, you can see it is a Muvattupuzha type 5 canal configuration, that is 1 canal dividing into 2. Then the second picture, you can see mandibular premolars with 3 canals and intercanal communication. Here also a maxillary second molar with 2 palatal canals and with intercanal communications. And from all these pictures, you can see that root canals are not just straight lines or curved lines. You should consider tooth anatomy as a root canal system rather than simple root canals. Then this is a maxillary first molar with 2 canals separating into 3 mesiobuccal root canals. So maxillary molar usually have 3 roots and usually will have 3 or 4 canals. Mesiobuccal root will have 2 canals, but very rarely you can see 3 canals. So sometimes we may see a lot of cases like that. That is poorly treated root canals staying inside the mouth for 10 to 12 years without causing any complaints. Sometimes in the radiographs, you may see these type of lesions, but the patient may not have any complaints. But even a very good operated root canal may cause pain. We can call it as endodontic paradox. But our aim is to do predictable endodontics. 100% of cleaning of these type of anatomical complexities is a Herculean task. So we have to clean, shape, and fill as much as possible. So in order to do a predictable endodontics, we have to identify the potential missed canals and operate them. So we can call these type of operations as a fuming volcano. They may not cause any problems for some period of time, but at a period of time, sometimes it may cause a problem. So first one is radiographic diagnosis. In radiographic diagnosis, a sudden shift in the radiographic density of the pulp space usually suggests the presence of an extra canal. You can see in this picture, from here, the radiographic density changes. It is a mandibular anterior tooth, and mandibular anteriors usually may have a lingual canal. So there may be 2 canals, and from this picture, you can see there is division of the canal. Then a sudden constriction or disappearance of the root canal space indicates a bi or trifurcation. This is a mandibular premolar. You can see from here, the root canal outline is not easily traceable. So there may be a division of the canal. Then sometimes post-operative radiography can also reveal the presence and location of additional root canal. So post-operative radiography is also very important. Here you can see this was a maxillary molar, and there is a periapical lesion in relation to the mesiobuccal root. I located 3 canals, mesiobuccal, palatal, and distobuccal canal, and operated. But after operation, when I took the post-operative radiograph, I could identify some sealer flow into the another canal, that is MB2 canal, which was originating as a deep split from the mesiobuccal canal. So initially, I was not able to locate that MB2 canal. But since you can see the portal of exit of these 2 canals are separate, these 2 canals are not merging together, and there is an associated periapical lesion in mesiobuccal root. Sometimes, if it is not cleaned and operated properly, it may cause a problem at a later stage. So I recall the patient in the next visit, selectively retreated the mesiobuccal canal and operated the mesiobuccal canal. So in this case, the post-operative radiograph helped to identify the missed canal. So good irrigation protocol sometimes may reveal these type of anatomies. Then there may be a missing canal if the root material is not centered within the root. This also is an idea. Sometimes if you are taking a master cone or a post-operation radiograph, and if you are seeing that there is some offshooting or off-centering of the master cone or operation material, you can suspect an additional canal. Here it was a maxillary second premolar. I got 2 canals, buccal and palatal, operated it. Some first molar also there was 2 mesiobuccal canals you can see. But when I took the post-operative radiograph, the buccal canal appears to be shifted towards one side. So there may be chances of an additional buccal canal. Then again re-entered and found distobuccal canal, which was very close to the mesiobuccal canal. So this was a 3 canal maxillary second premolar. Magnification can be achieved by 2 ways. One is dental loops and with lights. Then dental operating microscope. This will give a good magnification and illumination. At least a magnifying loop will be very helpful, and if possible, try to incorporate operating microscope also. Then there are some tests that can be useful in locating the root canals. That is champagne bubble test. Champagne bubble test means once you have instrumented the primary canals, suppose if it is a maxillary molar, mesiobuccal, distobuccal, and palatal canal you negotiated, fill the pulp chamber with hypochlorite. Then under the magnification, sometimes you can see some bubbling effect from the missed mesiobuccal canal, MB2 canal. So the pulp tissue in the MB2 canal may react with the hypochlorite inside the pulp chamber, will give an bubbling effect. This is called champagne bubble test. Then various dyes like methylene blue, ophthalmic dyes, etc. can be used to stain the pulp chamber and will help in identifying the missed canals. Then trans illumination using fiber optic lights. Then red line test, white line test, and perioprobing that we will discuss in the following slides. What do you mean by red line test is very simple. Red line test means usually blood oozes from an orifice, isthmus, or fins in vital tooth. So in such cases, you can see that usually the root canal may be slightly oval or there may be an isthmus. So in such cases, you have to instrument that area. Also, a red spot on the lateral aspect of a paper point is occasionally seen, which is thought to be an accessory canal. So, suppose this lateral, this can also happen with lateral perforation or strip perforation. But if you are confident that your instrumentation protocol is proper, and if you are seeing this type of bleeding points, sometimes there may be an accessory canal. Then white line test. White line test means dentinal dust collects into accessible anatomical areas when doing ultrasonic procedures in necrotic teeth without using water. When you are instrumenting in a necrotic tooth, when you are toughening the pulp chamber with ultrasonic tips without water, some mud will be created. Suppose you are searching for an MB2 canal. Some dentinal mud will be created, debris will be created. This will collect into the anatomical isthmus or orifice, difficult orifice areas. So this dust appears as a white dot or white line inside a hidden orifice or anatomical isthmus or groove. So this will help in the identification of elusive canals. So this is the most common easy classification of Wien's classification of root canal configurations. Then this is Muvattupuzha classification. You can see there are n number of possibilities. I will share one of my case which failed. Actually, this was a mandibular second molar. Access was little bit difficult. I got only two canals, one mesial and one distal canal. Then after a period of time, the patient came with a pain and with a sinus opening. When I traced the sinus opening with a GP, there was a lesion in the mesiobuccal root. We decided to retreat the tooth. Although I tried my best, I couldn't locate any other canals. But the medicament Metapex flowed into another canal. That is a deep split. Mesiolingual canal was originating as a deep split. But I couldn't properly clean and operate that canal. And ultimately, the patient again came with pain and the tooth got extracted. So even such small anatomies may cause problems in some cases. So do a prior assessment of canal curvatures based on preoperative radiographs and assess the difficulty or risk associated. And if you feel that if you can do it by yourself, proceed. And if you find it difficult and if you want some helping hand, you can refer the case. So how to study the root canal anatomy? Root canal anatomy, you will get a lot of articles from the textbooks, internet, and all this literature will help in identifying the root canal anatomies, studying the root canal anatomy. Then root morphology. Root morphology, the best way to study the root morphology is to examine an extracted tooth whenever you are getting a chance. Then evaluate the 2D radiograph. But the main disadvantage is that only the curvature in the mesiodistal plane can be seen on a radiograph. So always keep in mind that there will be curvatures in the buccolingual plane also. For example, maxillary first molar, the palatal root may have a buccal curvature. From a 2D aspect, you may get this type of straight appearance. That is, this type of the palatal root may appear straight, but here you can see there is a buccal curvature. So if you're getting a sudden stop when you're instrumenting the palatal canal, you have to give a buccal curvature. This is the most normal variation. So knowing this knowledge, knowing this anatomy will helps in the instrumentation of palatal canal. So always you have to visualize from both aspects. Then slope, as you all know, slope means same side lingual, opposite side buccal. In many cases, like mandibular molars, the mesiobuccal and mesiolingual canal may be in the same plane. So you have to give a horizontal shift about 20 degrees, which will help to visualize the mesiolingual and mesiobuccal canal separately. Here also maxillary premolars also, this is very helpful. Then you have to determine the point of penetration. Usually the point of penetration will be at the center of the occlusal table, but there are exceptions like maxillary molars in which the point of penetration is towards the mesial aspect. Then assessment of the occlusal and external root form is also very important. The burst angulation in 3 dimensions has to be mentally envisioned. And consider the angulation of the teeth in the jaws and assess the external root surface at the level of the CEJ. This is very important because the many tooth may have a constriction in the CEJ region. So the pulp chamber or the root canals will be centered at the level of CEJ, not from the occlusal aspect. So you have to consider that when you are doing an access cavity preparation. The center of the tooth has to be evaluated from the CEJ aspect. Then radiographic measurement of the depth of the pulp chamber roof from the occlusal is very important. Then assessment of complicating factors by reading the 2D radiograph, like rotation or tipping of the teeth. If there is any tipping or rotation of the teeth, the access will be a little bit difficult. You have to modify your access or angulation of the burrs accordingly. Then calcification. If there is calcification, you won't get any drop when you are opening the pulp chamber, and you will find difficulty in locating the root canals also. There may be pulp stones, calcifications, etc. And also deep restorations, also very difficult because you may not get any drop in this case also. Chances of calcification is also there in deep restorations. Then buccal and lingual restoration. Usually if there is a buccal and lingual restoration, there may be calcification. So this is also a very difficult job. Then root length. If it is a very long root canal instrumentation will be difficult. Then root width. If there is the width of the root is very wide, then chances of finding extra canals is very high. Then if there is any curvature, you have to be more careful. Actually, this was a case referred to me. The root canal looks very nice. Actually, it was retreated by an endodontist also. But the patient complaint was, the patient is not having any severe pain or complaint, but the patient is having sensitivity to hot foods. That was the main complaint. So already it retreated once, and the patient was going abroad and patient was concerned about this. So in an IOP also, it looks good, but you can see the mesiobuccal root is a bit wider. So chances of an additional canal may be there. We took a CBCT. You can see here between mesiobuccal and mesiolingual canal, there is one radiolucent line, which may be an indication of middle mesial canal or isthmus. And here also you can see a radiolucent line, which is confluent with the mesiolingual canal. So there is chance of a missed middle mesial isthmus or canal. But just because of this canal, the patient is having sensitivity to hot foods. Retreated, you can see a middle mesial canal joining with the other mesial canal and completed the operation. The patient was completely asymptomatic now. Is asymptomatic now. So CBCT is helpful in difficult cases to find the difficult anatomies, to find out the missed anatomies, etc. Then isolation is very important. Then pre-endodontic buildup using any restorative material or liquid dam or gingival barrier can itself be used for pre-endodontic buildup, so that your irrigation will remain inside the pulp chamber. Then you have to use front surface mirror. Front surface mirror will prevent double images. So this type of front surface mirror will help in giving a good clear images. Then burrs choice according to the clinician. I usually use these type of round burrs, and straight fissure burrs I usually use. The pulp chamber roof and floor distance is very high, or if the root canal orifices are very deep, you can use tapered fissure burrs like long shank burrs. Then once you got a dip into the pulp chamber, you can use these type of burrs, endo Z burr, that is safe and burrs, to remove the roof. This is very helpful. These all things will be taken by in the following classes. Then endo access burrs are there, but this burrs is bulkier, so it is better to avoid in smaller tooth. This is the advantage of safe and burrs. It will prevent nicking of the floor. So even if you are touching here, the safe and burrs won't cause any problems. Then DG16 Explorer is very helpful to locate the canal orifices. Then you need a sharp spoon excavator to remove the caries. Then ultrasonic tips. Startex 3 is a very good tip, but it is costly. You can use woodpecker tips like E5D and P4D, very helpful tips for removing the calcification and obstructions. This is how we use DG16 Explorer to locate the canal orifice. Then, as you all know, we need a straight line access. Access cavity should be conservative, but not ultra conservative, especially in the initial stages. If you are not having high magnification, go with the traditional access cavity, especially in difficult cases. When a straight line access is achieved, the file will not have to bend to get into the root canal orifice. So from this picture, you can see this is a straight line access. For this, you can slightly modify your access cavity with endo Z burrs like safe and burrs. Then ultrasonic tips like Startex 3, RS1 from Cybron Endo, E5D and P4D are economical versions from Woodpecker. Then long shank burrs can be used, which can be connected to your normal endomotor or quadrangle handpiece. LN burr, messenger burr, mullen burrs are examples. These are the ultrasonic tips that can be used for removing calcification. Then your axial wall has to be extended out of the orifice level. This is the correct opening. Otherwise, it is called rat hole preparation. The instrumentation will be insufficient. It may cause unnecessary stress on the instrument. Then this is one of the best studies, that is Krasner and Rango's law of access opening. First one is law of centrality. The floor of the pulp chamber is always located at the center of the tooth at the level of CEJ. So CEJ is the most consistent landmark. So CEJ is the most consistent and repeatable landmark for locating the position of the pulp chamber. Then law of color change is very helpful. The color of the pulp chamber floor is always darker than the walls. So floor is always darker than the walls. So when you're getting this dark picture, it means that you have reached the floor. This is the law of concentricity. This is the floor wall junction. You can see the color change. So then law of symmetry, except for maxillary molars, the orifices of the canals are equidistant from the line drawn in a mesodistal direction through the pulp chamber. You can see mesiobuccal and mesiolingual canals are equidistant. So if you are getting two canals, distal and mesial, and if it is slightly out from the center, you should suspect an additional canal. Then law of symmetry 2, except for maxillary molars, the orifice of the canals lies in a perpendicular line drawn in a mesodistal direction across the center of the pulp chamber. So if you are drawing a line perpendicular to this mesodistal line, the orifices will be located there. Then the orifices of the root canals are always located at the junction of the walls and floor. So this is the dark part is the floor, and orifices are located at the junction of these wall and floor. Then orifices of the canals are located at the angles in the floor wall junction. It is just the modification of the previous law. Then this is very important. The orifices of the root canals are located at the terminus of the root developmental fusion lines. You can see these are the fusion lines. Orifices are located at the terminus of these fusion lines. These fusion lines, dentinal grooves, are called dentinal maps, because this will helps in the locating the additional canals or normal canals, primary canals. So this is called dentinal map. So above laws are found to be true for 95% of the tooth examined. 5% of the maxillary second molars did not conform to these laws because of the presence of C-shape anatomy. C-shape anatomy we'll see in the following slides. So floor of the pulp chamber, as we said, it is always darker. Root canal orifices normally appears dark gray or black. But if it is a calcified canal, you can see it as a white spot. Otherwise, the orifice will appear as dark. Then pulp stone, white or yellow. So developmental lines can be seen connecting the canal openings, and tracing along this development line can reveal the location of undetected canal entrance. So dentinal map will be very useful. That is why when you are doing a root canal opening, you should not nick the floor. Because if you find difficulty in locating the canal, these dentinal maps will be the most useful guide. So on a background of yellow or gray secondary dentine, the canal opening will appear as a small region of white opaque dentine in calcified canal. Usual cases, the canal opening will appear as dark. But in calcified canal, the canal opening will be calcified, and such areas will appear as white, and the secondary dentine will appear more white, grayish or yellowish in color. So it is important to remember that secondary dentine is generally more whitish or opaque, whereas the floor of the pulp chamber is darker and gray in appearance while roughening the floor of the canal. Then we'll see one by one. One is mandibular anteriors. Mandibular anteriors, as you all know, it is a very small teeth. So you have to use very small burrs. And suppose if the canal is having some calcification, you have to take frequent radiographs. Suppose you have drilled 1 to 3 millimeter, 3 to 4 millimeter, you are not getting orifice, take a radiograph and make sure that you are going in the proper direction. Because even a slight change in the direction may cause perforation. Then use small burrs and always search for the lingual canal. There may be a lingual canal. So lower anteriors, and sometimes the lower anteriors may have a lingual tipping also, making access very difficult. So all these things should be taken care of when you are doing root canal treatment in a mandibular anterior teeth. These are the most common errors caused by errors caused in mandibular anterior teeth: missed lingual canal and gauging. So usually a buccal and lingual canal will be there. Here you can see a retreatment case, mandibular anteriors. All of these central and lateral incisors were having two canals which were merging together. You can see the healing. Here also you can see, as we have seen earlier, you can see a division of the canal. Usually mandibular anteriors, the buccal and lingual canal, labial or lingual canal will be merging. But very rarely you can see this type of configuration that buccal and lingual canals are having separate portal of exit. This was a RTA case and tooth became non-vital. That's why root canal treated. Here also you can see mandibular anteriors and canines are having two canals that are having merging type of anatomy. Here also you can see, from here you can trace that there may be a tooth canal. This is a rotated tooth, that is why it is giving such a clear picture. Here also a big lesion, but only one tooth was non-vital. So here also you can see two canals merging. Tracing, here also you can see sudden change in the radial density. here also. So all these canal root tooth may have two canals. The tooth lesion is healing now. Sometimes the buccal and lingual canal have some isthmus also. Here you can see it may be connected by isthmus. Good irrigation protocol is necessary. If this was a mandibular canine, you can see two canals having separate portal of exit. This is also a little bit rare. You can see. Then common errors in the maxillary anterior teeth. Here also you have to consider the palatal as tipping palatal placement of the root, and according to that you have to modify the angulation of the tooth, angulation of your burr. Then maxillary lateral incisor may have some curvature in the apical third, a distal curvature usually. Sometimes this is a case, you can see a small rudimentary root here. I was not able to locate the canal, and that was surgically removed, but the patient did not report after that. This was metapex. Here also a maxillary canine. You can see when you're having closer look, you can see two canals. There are some and merging together. You can see two canals merging. The lesion is healing now, but the two lateral was also non-vital. Initially, it was showing response in the cold test. Now I've started completed the root canal of 2 also and waiting for the complete healing of the lesion. Here you can see, actually when you are instrumenting the canine, I got some difference in the apical third. And there was some division in the apical third, deep apical split. Got separated one instrument there. Luckily, I got it separated. This type of division, sometimes this division part is very difficult. If you are not careful, you may separate in instrument in this division area. So here also, there was a deep division. It was a maxillary canine. Then common errors in the access opening of mandibular premolars. Mandibular premolars, as I said earlier, it is called endodontic enigma. So you have to search for the missing extra canal. Then there may be some mandibular premolars usually will have lingual tilting, buccal tilting, etc. So chances of these type of complications may occur. So the crown of the mandibular premolars is tilted slightly lingually towards the root. So that also you have to take care of. So the entry point is in the middle of the central groove and the burr is directed towards the buccal aspect. Your access cavity should be slightly extended towards the buccal aspect in normal premolar cases. As the crown is lingually inclined, the access cavity will result in the removal of more buccal cusp than the lingual. So if it is a single rooted premolar, your access cavity should slightly widen towards the buccal aspect. That is in the mandibular first premolar. Sometimes the tooth may have a lingual canal. This is a lingual inclination of the crown portion. If there is lingual canal, you have to extend the cavity to the lingual also. That we'll discuss. Slovy recommended that it is helpful to visualize the canal configuration as a lowercase letter h if it is a two canal morphology, two canal anatomy. You can see the lingual canal will appear as a sharp turn from the buccal canal. So here you should be very careful. Chances of instrument separation is very high. And also for locating this lingual canal, you have to modify your access cavity slightly lingually also. You have to extend slightly lingually also. The lingual cusp is very weak, so you have to be very careful also. So lingual extension exists. Lingual canal exists usually at the mid-root or apical third, and it originates as a sharp angle from the straight buccal canal. Usually, lingual canal will be from the mid-root level, but sometimes you can see two orifices from the coronal aspect itself. That will be more easy to instrument. But if it is a mid-root or apical third split, it is very difficult. In such cases, you have to slightly extend the lingual wall. The lingual inclination of the crown also makes little bit difficulty. The lingual inclination of the crown tend to direct your instruments buccally, so increasing the difficulty in locating the lingual canal orifice. So one problem is that lingual canal is originating as a sharp turn from the buccal canal. Then lingual inclination of the buccal crown portion is also will cause problems. To overcome this situation, the clinician need to extend the lingual wall of the access cavity more towards the lingual to find this lingual canal. What you can do is that you can use orifice openers or piezoremer 1 till this division to widen this coronal area. Sometimes you may see C-shape anatomy in mandibular premolar. C-shape anatomy is very challenging in mandibular premolars. Usually it is seen in mandibular second molars and third molars, but locating a C-shaped canal anatomy in mandibular premolars is very difficult than locating in mandibular molars, because in mandibular premolars, as you know, the crown size is very small. So visual examination of this C-shaped anatomy is very difficult. Then usually this C-shaped configuration will be placed more apically than molars and less visibility. So all these factors make a instrumentation of the C-shaped canal anatomy in mandibular premolars a Herculean task. And C-shaped canal premolars are very common in Chinese or Mongoloid population. A systemic literature review by Jojo Couture et al. Concluded that lower bicuspids are commonly found to have a single root that is greater than 97%. This is a very good article for PGs by Jojo. Then mandibular first premolars being comparatively twice more likely to present with 2 canals than second premolars. So mandibular premolars are more common with 2 canal morphology. Then multiplicity of roots, that is up to 4 roots, and root canals, that is up to 5 root canals, have been documented as case report in both lower and lower bicuspids. In first premolars, C-shaped canals show a higher incidence in mongoloids up to 24%, not a small number, while other common variations of first premolar include deep mesial invagination, radicular invagination, and dense invaginatus. And dense invaginatus is also very difficult to treat. So sometimes the mesial root have a deep groove. So in such cases, you have to be very careful when you are doing rotary instrumentation. Sometimes you may end up with root perforation, strip perforation. And there may be some clinical clues that will help in locating the additional canals. Sometimes the tooth may have altered crown dimensional, additional cusp, tubercles, deep longitudinal developmental groove, fusion of teeth, all points to anomalous tooth morphology, which could be accompanied by anomalous endodontic morphology also. So tooth morphology, if is slightly different, there may be slight difference in the root canal anatomy also. But if the tooth is carious and gives little information regarding the coronal anatomy, observe the anatomy of the contralateral tooth, which could give vital insights into the possible underlying anatomy. Usually, if the patient is having some abnormality or additional canal in one teeth, usually the patient may have a lot of anatomical variations. I got in one patient, I got 3 canal upper premolar, 3 canal lower premolar, 3 rooted mandibular premolar, molars, 2 on both sides. 4 root canals, 4 were different. So usually if the one side of the mandibular molar is having additional root, usually the other side also will be there. So you have to examine the contralateral tooth, which will give some vital inputs. Then gingival recession may reflect the furcal morphology in multi-rooted tooth, and this will hint the presence of 2 buccal roots, etc. Then probing the buccal sulcus to feel the root eminence and furcal anatomy may also help in the presence of buccal roots if present. So if the premolars is having 3 canals, mandibular premolars, where you have to look. The cervical half of the tooth is generally wider than the usual, with little or no taper. Usually the cervical taper will be less in such cases. Then two periodontal ligament spaces on one side of the root and the periodontal ligament space crossing over the root are important observation to indicate the existence of accessory roots. Here you can see two periodontal ligament space. So here you can see the tooth may have two canals and two roots. In single canal lower premolars, the axis can be somewhat more circular in shape. However, if a second canal or bifurcation is suspected, a buccolingually directed oval axis cavity is more accurate. And if you are suspecting a 3-canal morphology, you can make it into a triangular axis cavity. So if the pulp chamber appears to deviate from the normal configuration and seems to either triangular in shape or too large in mesiodistal plane, more than one root canal could be suspected. When you are opening, you are seeing that the pulp chamber of the premolar is little bit triangular. Then you have to look in both mesiobuccal and distobuccal direction. You have to put the instrument into both mesiobuccal and mesiolingual, distobuccal, like a maxillary molar. But thing is that since it is a small tooth, the mesiobuccal and distobuccal orifice will be very close to each other. So when one canal bifurcate into two, the division is most probably buccal and lingual. If it is a 2-canal morphology, usually it will be a buccal and lingual canal. With the lingual canal generally splitting from the main canal at a sharp angle, as we have seen earlier, like a letter H, sometimes at nearly right angle. So bifurcations are predominantly at the middle or apical third of the root also. If the bifurcation is from the middle third, it will be very difficult. So you have to put the instrument from the buccal side. And you have to give a lingual curvature to the file to get any catch. So it is challenging to determine the exact configuration of the canal system by visual inspection of the pulp chamber if it is a deep split. So we won't be able to see the split even with loops. Sometimes microscope will be very useful. So the root canal system of premolars with 2 roots and 3 root canals is usually characterized by one large lingual canal and 2 smaller mesiobuccal and distobuccal canal in buccal root. So if it is a 3-canal morphology, usually there will be 1 lingual canal and 2 buccal canals, mesiobuccal and distobuccal. Ordinola sapta assess the morphology of mandibular premolars with 3 root canals using microcomputerized tomography and concluded that triangular shape configuration of the canal orifice are more prevalent. If the canal is having 3 orifices, usually it will be triangular formation as we discussed earlier. But very rarely, a linear configuration could also be encountered very rarely. Sometimes the 3 orifices will be arranged in a linear pattern. These things will be a little bit deep, but it will be very useful for the PGs. So this is also a picture from Jojo's article. You can see buccal and lingual canals, 2-canal morphology. Here you can see mesiobuccal and distobuccal. This is the lingual canal. This is the 3-canal morphology. An important aspect that need to be considered during instrumentation of multiple canal in mandibular premolars is the presence of sharp curve, especially in the bifurcation or trifurcation area. So caution should be exercised during instrumentation along these sharp angles to prevent file separation. Because sometimes you won't be able to extend the lingual cavity, your access cavity towards the lingual aspect into a very good aspect because it may compromise the tooth structure. So there will be some hindrance during instrumentation of this lingual canal. Here you can see in this case, I actually separated one instrument in this separation split area. And luckily I could bypass it. Actually, initially I got the tooth canal, but I was not getting the patency in this canal. So I took the mastercon. Mastercon appeared to be short here. So I tried to again instrument that canal and finally got separated here an instrument. Luckily, I could bypass the instrument in the next visit. So tactile examination of the walls of the major canal with the tip of a small pre-curved scouting K-file is recommended. So tactile examination is the key point. You have to pre-curve the K-file into the lingual aspect, insert it with some buccal inclination and check for any catch. So if you are getting any catch, it may be an orifice of the additional canal. If the division is from the coronal aspect, you will get easily. But if it is a deep split, it will be very difficult. The presence of additional canal should be suspected when an instrument demonstrates an eccentric direction or deeper penetration into the canal, which is termed as directional control by green. Sometimes you are getting some directional. When you are putting a file, you are getting a sudden resistance or you are getting a deflection in your instrument. It is called directional control. Then Sandhi et al. Reported excessive thinning of the root dentine in deep developmental grooves up to 0.8, 0.78, and 0.3 millimeter, respectively in the coronal middle and apical third. So sometimes there may be a mesiolingual groove in the mesial aspect. So you should be very careful. And these type of grooves are very common in C-shaped canal. Here you can see the groove. Here only 0.5 millimeter is there. Here you can see 1.6 millimeter. So if you are removing a lot of dentine here, it may cause strip perforation. This is the groove present, mesial aspect. Such minimal thickness of the root dentine could certainly render the tooth vulnerable to failure from treatment procedures. So the clinician should be careful in instrumentation of the mesial surface of the canal, and overzealous instrumentation can lead to strip perforation. And also when you are doing warm vertical compaction or continuous wave of compaction, the heat transfer may cause damage to the periodontium. So this is also a concern. Then the most difficult part in mandibular premolars is operation. So usually root bifurcation or trifurcation can occur at the level of cervical, middle or apical third of the mandibular premolars. So you have to modify your instrumentation or operation protocol. If it is a cervical third trifurcation or bifurcation, which can be operated with any technique like lateral compaction or continuous wave of compaction or single cone operation with bioceramics, it will be very easy. But if it is a middle third operation, one technique by suggested in Jojo's article is that when coronal space is insufficient to accommodate the multiple master cone, usually you won't be able to put all the master cones simultaneously into the deeper divisions. So in such cases, a larger master cone can be cut extraorally at the level of bifurcation or trifurcation, and you can attach a spreader like this to the cut end of the GP and rotate the file in clockwise rotation. The Kataparcha cone is then introduced into the canal, and rotating the file counterclockwise using apical pressure loosen the file and prevent blockage of the unfilled canals by sealer or remnants of the Kataparcha by placing paper points or hand instrument within the other canals. So this is one technique suggested by this article. Remaining canal can also be operated similarly. So after radiographic confirmation, you can backfill the coronal third of the root canal with a backfilling device. Suppose if it is an apical third bifurcation or trifurcation. Operating such root canals requires good clinical skills with dental operating microscope and higher depth of focus. One technique suggested is called squirt technique. That is, injectable Kataparcha can be used if you are getting good visualization of this apical third split. In this technique, both end of the root canal operated simultaneously by injecting the thermoplasticized Kataparcha, followed by backfilling. So for that, you need microscopes. Alternatively, another technique is that 2 or 3 master cones are used with each one being sheared at the apical or by trifurcation. That is, down pack device is there. You can cut off the coronal GP with the device and allowing room for the next cone to be seated. So once you can place 2 cones if it is possible, then down pack it with the down pack device so that the coronal GP will be removed, then place the other cone. Once the individual canals in the apical thirds are filled, the coronal canal can be backfilled. So here also maintaining the patency of the offshoot canal is very important. For this purpose, a file can be placed to prevent the blockage. Additional canals are then filled similarly, followed by coronal backfilling. Here you can see it is a premolar. Here, actually, it is a multi-canal premolar, but they missed. Actually, this is a nicely operated primary canal, but there was additional canals. That is why this case failed. Here you can see there are two canals, but the the origin of these canals are from the coronal third itself. So it is very easy. And both of these buccal and lingual canals are merging. But here you can see premolar. There may be some splitting of the canal, middle third. You can see buccal and lingual canals. And you can see buccal and lingual canals here. Here also, you can see some difference. There may be two roots or two canals. You can see the lingual canals has sharp turn from the buccal canal. Here you can see the two canal morphology. Here also you can see there is a shadow of the root, also a canal. Two canal morphology. Here also you can see two canals, separate portal of exit. Here also, here the division is from more coronal third. It is very more easy to negotiate. This is also two canal premolar. It is a retreated case. Actually, here one more canal I suspected, but I couldn't negotiate that. Two canal morphology of two premolars, 4 and 5. Here also you can see two canals. Here also you can see sudden disappearance of the root canal outline, maybe division of the canal, 3 canal. Here also, if you're closely tracing, you can see an offshoot. The lingual canal appear as an H-shaped letter. You can see lingual canal. Sometimes the two canals may be connected by isthmus also. Here you can see the isthmus. This is two canals merging together, which is more easy to instrument, and the orifice are much more coronally. Here also, it is an endoperio case. Here also you can see a two-rooted premolar, deep division at the mid-root level. Here also, two-rooted canal. In the preoperative radiograph, it is not so clear, but you have to, some difference is there. So search for the additional canal and could find one. Here also you can see the preoperative radiograph, some difference is there. This was also a referred case. The doctor identified the second canal, but he was not able to negotiate that. So giving a lingual curvature helped to negotiate this narrow lingual canal. So this is a premolar. Here also you can see sudden difference in the radiographic shadow. So there is here also. So reading the radiograph is very important. Here also you may see some difference. Here also you can see two canal. Here also you can see division of the canal. These are premolars. Here also you can see sudden narrowing. This is three-rooted premolar, both 4 and 5. Two-rooted canals. These type of divisions are much more coronally. It's very easy, but these type of divisions are apically more difficult. Here also you can see division of the canal here. Here also you can see division. Here also the canal appears straight, but some difference here. So there is a division of canal. All these are division. This was one of my case years back. I lost my preoperative and all these things. I didn't took the postoperative radiograph. At that time, usually completing, we're doing the root canal with just apex locator and all these things. Look very simple, large canal premolar, completed the operation. And after 2 or 3 days, the patient came with swelling. It was a consultation case. So when we took the postoperative radiograph, I could see some sealer flow into this lingual canal. And that helped to identify the lingual canal. So if I would have taken one postoperative radiograph, I could have negotiated at that time itself. But when the patient reported with the pain only, I took the postoperative radiograph and could find that sealer flow. Then reopened and negotiated the lingual canal, and the patient symptoms subsided. Here also, you can see clearly two roots. Here you can see sudden disappearance, so two canal. Here also you can see two canal morphology. Here also you can see division of the canal, two canal deep division. So all of these things you can see division. So radiograph reading is very important. Then this is a referred case. This is very, actually I don't have a thermoplastic gutta percha unit or microscope with me. I use loops. So operating this canal was a bit difficult for me. What I used is a technique called ultrasonic compaction. It is similar to a warm vertical compaction, in which we use ultrasonic spreader tips to compact the GP. So placed the cones here, but simultaneous placement of all cones were a bit difficult because here the cone is not going. So place the two cones simultaneously in two canals and operated the canal. Then after that, I inserted the ultrasonic spreader and removed the coronal GP and placed the other master cone in the other canal. So in such deep divisions, ideally you should have microscope and thermoplastics operation units, but sometimes you can use this technique also. So one canal dividing into three as a deep division in such cases. Orifices were not easily visible even with magnifying loops. So for instrumentation also, you can use a technique called manual instrumentation. You can use your rotary instrumentation in manual technique because nowadays nickel titanium instruments are coming with heat treated quality. So you can pre-curve the rotary files also and can be inserted. Then another technique called tactile controlled activation, which is also very useful for deep split of the canals. You can check it in the YouTube TCA technique. I forgot to add the video here. TCA technique means tactile controlled activation by Antonio Chando is basically you can pre-curve the rotary files and insert into the deep division and then activate. Usually when you are inserting the rotary instrument, it will be rotating when you are entering into the root canal. But in this technique, you have the instrument won't be rotating. You have to pre-curve the file and insert into the root canal until you get a resistance, and then you will activate. The another difficulty in treating such cases is placement of all master cones simultaneously. So simultaneous placement of the master cone in three canals will be a bit difficult. So what I have done is placement of two master cones simultaneously with up and down motion. You can slightly push and pull. You can insert two master cones into the canal. Then laterally compact that both canals. Then insert the ultrasonic spreader into the till the split area and remove the coronal GP. Then use specialized pluggers called flare spreaders, that is 5% spreaders, and you place the GP cones into the third split. And confirm with IOPA that your master cone is going into the deep split. So this is called ultrasonic compaction. You can use, these are the ultrasonic spreader tips I mentioned, E4 and E5 tips. Then these are the spreaders, that is 4% and 5% spreaders are available, which can be used for this technique. This was also a C shape, possibly a C shape. I am not sure whether it's C shape because I was not able to visualize the canal configuration. But there was some deep split, and here also placing all master cones was simultaneously was difficult. Two master cone placement was possible, but the third one was not possible. So operated two canals initially, then removed the coronal GP till here with the ultrasonic spreader tip, then place the third master cone here, and then again compacted. So you can see 3 or 4 portal of exit is there. Here also is possibly a C-shape premolar. You can see here also it is completed like that. Sometimes there may be deep split or apical delta also. So mandibular premolars are very notorious for apical delta. Here also you can see, sorry, I missed X-ray. I missed the obturation X-ray here. There was a apical delta. Then next is maxillary premolar. Usually the tooth may have buccal and lingual canal, two canal, but very rarely you may have three-rooted maxillary premolar or three-canal maxillary premolar. In such cases, it is like a small molar tooth, molarized premolar you can call, and you can see mesiobuccal and distobuccal canal orifice here. So sometimes you may clearly get this picture. The pulp chamber will be a little bit triangular. You have to search both buccally, mesiobuccally and distobuccally. But sometimes initially when you are opening, you will get only two orifices, but there may be a third canal. But there are some clues that will help in identifying there may be an additional canal. Sometimes if you are instrumenting the buccal canal, if you are getting a sudden stop or high resistance during instrumentation compared to the palatal canal, your instrument is not going very nicely into the palatal canal, it is very normal, but you are getting sudden stop or high resistance during the instrumentation of the buccal canal. The buccal canal is very narrow, or it is the instrument is hitting like into a hard stop. Then there may be a division. This may also happen with buccal restoration. If there is a cervical restoration, there may be calcification and you may get this type of problem. But if there is no any pulp calcification or cervical restoration and you are getting higher resistance during buccal canal instrumentation, you should suspect additional buccal canal and you have to search mesiobuccally and distobuccally. But unlike molars, these mesiobuccal and distobuccal orifices will be very close to each other. And sometimes this division may be originating as a deep split from the same canal. So initially, there may be for the initial coronal 3 or 4 millimeter, there may be a single orifice. And after that, the buccal canal may be dividing. So what you may feel that you are getting is that your instrument is getting a sudden stop here. And after that, you are not getting any, your instrument is not going. So in such cases, you have to give slight deviation in the direction. So increased resistance or sudden hindrance in the buccal canal compared to the palatal canal may be an indication of multiple buccal canals or division of the buccal canals. Here you can see actually the canal was, this was a 3-canal premolar. Here you can see mesiobuccal and distobuccal too close to each other. Here you can see buccal canal actually originating as a single orifice, but deep it is splitting. This is also a 3-rooted premolar, maxillary premolar. Here also you can see from the preoperative, operative, 2 root canal outlines are there. So actually it is a, you can see the width of the premolar here. It is a molarized premolar. So in such cases, you have to suspect the additional anatomy. Here you can, if you're, sorry. If you're closely watching, you can see some difference here. So it was also a 3-canal premolar. Here also a deep division of buccal canals. Here also you can see. Here actually I was getting only 2 canals, but I got higher resistance in the buccal canal. So search for the additional buccal canal. Here this was also similar case. Buccal canal, I got higher resistance, so search for the additional canal. Here you can see deep split in the canal. It was only, I felt some difference during the instrumentation, but only post-operation radiograph revealed that division. Here also I felt some difference, but I didn't suspect any canal. But here in the post-operation radiograph, you can see divisions. Sometimes coronally premolar may appear, especially second premolar, the orifice may be single, a wide oval orifice, but deep in the canal, it may dividing into 2. In such cases, what you have to do is that even though it is a single canal, you have to instrument like 2 canals from both buccal and lingual aspect. Here also, coronal it is originating as a single canal, but deep it is dividing into 2. So it is can be considered as a 1-2-2 morphology. one common mistake that we initially do in maxillary molars during access cavity preparation, it was one of the common mistake that I was usually doing my post-graduation days. You will go like this because you have to consider this CEJ part. You have to consider this cervical tapering. So chamber will be here, the center aspect. So if you are considering from the occlusal aspect, you may end up like this. You may end up creating a perforation in supragingivally in this or crustal area. So you have to go inside. So your bar should be angulated towards the inside of the aspect. This is the location of the MB2, most common location. Usually if you are drawing a line from the mesiobuccal canal to the palatal canal, usually in this line or slightly mesial to it, you can see the MB2 canal orifice, usually close to the MB1. Sometimes you may see here also. So this is the common location of the MB2 canal. So MB2 canal, usually you have to trace this dentinal map. Usually they may be connected by these grooves. So in the end of this groove, you can see the MB2 canal. So this is the possible locations of the MB2 canals. So MB2 isthmus, that is the MB2 groove, can be considered as the holy grail of MB2 hunts. And because it is the palatal extents usually point directly towards the hidden MB2 orifice. And also, if you want to make sure that you didn't miss any MB2, you should take a distally angled radiograph. And if you are seeing that your file or mastercon GP is off-centered, there may be chance for a missed MB2. Sometimes the MB2 canal are having separate portal of exit. Sometimes they may be merging. If it is a merging type of canal and if your apical seal is very good, it may not cause any problem. But if it is a separate portal of exit, sometimes it may cause problems. And about 90% of the maxillary first molars have MB2 canals. That is the easy, difficult part. So you can see this is merging type of MB2 canal. These are separate portal of exit. Here also, if you are having suspicion, you can check a working length radiograph by putting instrument. These are MB2 canal. Sometimes MB2 canal will act as a savior. Here, actually, this was a RCT done on my orthodontist by a previous dentist, and the patient, doctor was having sinus opening, and there was instrument separation in both mesiobuccal and distobuccal canal, but I couldn't bypass the instrument in the mesiobuccal canal. So what I tried is I negotiated the MB2 canal and placed medicament inside the canal, and the sinus got disappeared. Luckily, the MB1 and MB2 canal were merging. So properly operating the MB2 canal eliminated the lesion. Here also you can see MB2 canal in upper second molar. MB2 canal. Here also you can see division of the canal. So there may be chance of an MB2 canal. Initially I was not getting the MB2 canal. Then I again tried and got the MB2 canal. This is a retreatment case, both in maxillary first and second molar MB2 canal was there. Here also MB2 canal. Sometimes the MB2 canal may have a severe curvature also, making the instrumentation more difficult. Here also MB2 canal, MB2 canal. These are all MB2 canal. Sometimes you may get an MB3 orifice, but usually it may merge with the MB2 canal or MB1 canal. Here you can see MB2, DB2, distobuccally 2 orifice, mesiobuccally 2 orifice, but they are merging together. These are all MB2 canal. Here you can see the patient was having, it is a decently operated molar, but the patient was having pain. So a distally angled radiograph help to identify the missing canal. The master cone is off-centered and there is a radiolucent line. There may be a possible missed MB2 canal. Could negotiate selectively retreated the MB2 canal, mesiobuccal canal. This is maxillary second molars may have different anatomies. Here you can see altogether different anatomy. Here you can see MB1, MB2, MB3 joining together, and MB1 mesiobuccal and distobuccal canal also joining together. Here also MB2 canal, you can see the isthmus between the MB1 and MB2 canal. So it is a root canal system rather than here also MB1, MB2, MB3, but they are joining together. So this is the distal angle radiograph, which will help to see the MB2 canal. Sometimes you have to give a mesial shift, but usually a distal shift will help in the MB2 canal visualization. This we already see. Here you can see some difference. So chances of MB2 canal is there. But interestingly, after operation, I could find MB3 canal also. That is 3 canals with separate portal of exit, MB3. It's very rare. Sometimes you may get 2 palatal canals. Usually they may be joining together. Maybe because of some calcification and all these things, you may get 2 palatal canals. Deep palatal splits, you may see MB2 also there. Here also you can see MB2 and palatal, 2 palatal canals. Here you can see DB, MB1, MB2, MB3, P1 and P2, palatal canal, 2 canals. Sometimes the maxillary molars may have 2 palatal roots also. Here you can see some difference in the radiographic appearance. There was 2 palatal roots. So 2 palatal canals, mesiobuccal and mesiopalatal and distopalatal, 2 buccal orifices. Here also you can see some difference in the preoperative radiograph. There was 2 4-rooted maxillary molar, 2 palatal orifices you can see. This was a maxillary 3rd molar. You can see 4 roots. Then you can sometimes you may get deep palatal splits like this. This is also maxillary 3rd molar, some different anatomy. Mesiobuccal, MB1, MB2 palatal, all canals were merging. Distobuccal was having separate portal. Next is maxillary 2nd molar. Usually maxillary 2nd molars, the distobuccal and mesiobuccal canal orifice will be like this. The angulation will be slightly different than the maxillary molars because of the more ovoid shape. And sometimes you may get a 2 canal morphology or even a single canal morphology. Or sometimes the mesiobuccal and distobuccal canal may be look as a single orifice, but from the same orifice, distobuccal canal may originate. So maxillary 2nd molar is also very notorious. Sometimes we may miss the distobuccal canal. Here actually the 2 orifices were there, but you can see the mesiobuccal and distobuccal canal was connected by a wide isthmus. So clinically, there was only 2 orifices. Here you can see it is a conical root. I suspected it may be a single canal maxillary 2nd molar. I thought it may, we can finish the case very fast. But interestingly, you can see MB1, MB2, palatal and distobuccal. 4 canals was there in this small tooth. Here also, sometimes the distobuccal orifice may be very close to the palatal canal, and it may appear as a narrow opening also. In such cases, it will be very difficult to negotiate the distobuccal canal. So sometimes the mesiobuccal and distobuccal canal may be very close. Sometimes the distobuccal canal may appear close to the palatal. So all these anatomical variations makes maxillary 2nd molar very difficult. Also accessibility. Then next is mandibular 1st molar. Usually access preparation often encroach the buccal cusp tip, but rarely onto the lingual cusp. Usually our access preparation should be slightly buccal when you are looking from the occlusal aspect. However, the access will be located largely in the mesial half of the tooth. Sometimes it is necessary to encroach into the mesiobuccal cusp tip to achieve straight line access also. Usually, this is the common 3-canal morphology, but usually your access cavity should be a bit wider here and search for this lingual canal also. And sometimes you may see middle mesial canal, middle distal canal, all these things. And usually the distal canal may have a distal exit. So if you are getting a sudden stop in the distal canal, you have to pre-curve the file into the distal aspect. Sometimes that distal root may have a distal exit. Then middle mesial canal or middle mesial isthmus, you can see it may be usually joining with the other mesial canals. Here also you can see isthmus also. MB1, 4 orifices are there, but it cannot be called as true canals. Maybe an wide isthmus. Here also you can see 3 lines. So possibly there may be a middle mesial canal. There was a middle mesial canal, merging type of middle mesial canal. Here also middle mesial canal. Here you can see wide isthmus, 4 orifices are there connected together. Middle mesial canal. Sometimes, very rarely, mesial roots may have 3 portals of exit. Middle mesial canal. So usually there may be a groove between the mesiobuccal and mesiolingual canal. And you have to toughen that groove with ultrasonic tips very carefully and try to get any catch with your K files. So if you are getting any catch, it may be an indication of an isthmus or middle mesial canal. These are converging type or merging type of middle mesial canals. Sometimes the orifices may be very close together to either mesiolingual or mesiobuccal canal. These are all middle mesial canals. Here also there are merging type of middle. Mostly these type of canals may be merging together. I started to search middle mesial canals after seeing some of my failures. So missed middle canals. Actually, this patient, this was completed by another doctor. The patient operation looks very nice. And when I retreated, I could find this middle mesial canal. Actually, because of this shift in this X-ray, you are seeing this. If you are taking a straight X-ray, you won't see, you will see like this only. Shift X-ray, you can see middle mesial canals. So maybe because of the middle mesial canal, you are getting this type of picture. This is called halo shape radiolucency or J shape radiolucency, which is a most common feature seen with the vertical root fractures. But middle mesial canal also, if you miss, you may get this type of picture. Here also, you can see a halo shape radiolucency here. Here also you can see there was a missed distolingual canal and a middle mesial canal. This was also my own case. I completed this case in 2015. A patient came with pain in 2015, 2014 or 13, I completed this case. So when I retreated, I could find a distolingual canal and middle mesial canal. Then in 2017, it is completely healed. This was also my own case where I missed a middle mesial canal. So here you can see lesion in the mesial root. Here, this was a case referred to me. Here the lesion root appears very good. Operation appears very good. The patient was having pain. There was a lesion in the mesiobuccal root. After retreatment, you can see 3 portal of exit. Sometimes a furcal radiolucency or halo shape radiolucency may be an indication of furcation canals, deep isthmus or middle mesial canal. Here you can see halo shape radiolucency. This is metapex. So you can see furcation canal here. All these are some clues. Here you can see furcation radiolucency. It may be because of the middle mesial canal. So always look for a catch between the mesiobuccal and mesiolingual orifice. Use ultrasonic tips or at low power to widen the isthmus if present. Use DG16 Explorer or small size K files for initial exploration. Then I usually use, after using all these things, if I couldn't find any catch, what I usually use is ProTaper S1 file, universal file, 21 mm, in a very slow speed like 200 or 250 RPM to get any catch in the possible locations of the middle mesial canal. This is very useful. You can slowly, you can use this S1 file to get any catch. If you are getting any catch, just widen that area, then again use hand file to locate the canal. So S1 file is very useful. Then possibly a distal shift X-ray will help to visualize the middle mesial canal separately. Here also you can see separate middle mesial canal. This was an open apex case with the middle mesial canal. MTA barrier was created. Here you can see the isthmus between the middle mesial. In young patients, lot of chances of finding MB2 is very high. This was metapex. The patient didn't report it. You can see the furcation radiolucency here. Usually, if you are seeing this type of isolated furcation radiolucency, it is maybe related to endo rather than perio. The patient overall oral hygiene is very good, and there is furcation radiolucency. Doing a good endodontic treatment itself will heal this lesion. Sometimes you may see middle distal canal also, middle distal canal or middle distal isthmus also. Here you can see middle distal canal or distal isthmus. Here also you can see a middle distal canal. Here also you can see middle distal canal. And this was the third molar. Actually, the distal canal were splitting into three, and mesial canal were joining with the distal root. So coronally, there was only one division, but when you are doing instrumentation, felt some difference. Here you can see some difference here. Here also, deep split of the distal canal. I was not able to place two master cones simultaneously, so use ultrasonic compaction here. Here you can see deep split of the distal canal. Here you can see young patient. This is the mesial root. Sorry, this is a distal root. This is a mesial root, I think. Sorry, this is a distal root. This is a mesial root. Same tooth. You can see by giving shift X-ray, you can see the isthmus between these canals. Young patient, you may see like this. And sometimes you may get two roots, mesially two roots. This is called radix paramolaris. There is a middle mesial isthmus also here. So radix paramolaris. Here you can see two roots, mesially two roots are there. Then radix endomolaris, that is distally two roots. And sometimes you should be very careful in identifying this root. Otherwise, you may miss this distal lingual canal. So usually in distolingual canal, if there is an additional root, distolingual root is there, you have to slightly widen the access cavity distolingally. Then only you will get the distolingual orifice. So preoperative radiograph reading is very important. You can see two periodontal ligament space here. And also here, sometimes you may get a clear picture here. So it is two-rooted distal root. These are some radix endomolaris. And another thing is that many times this additional distolingual root may have multi-planar curvature. That is, the tooth may have mesodistal curvature and buccolingual curvature. And this buccolingual curvature may not be visible in the radiograph. So the instrumentation in the apical third will be very difficult. And chances of instrumentation separation is also very high. So you should be very careful. This was a case where I separated an instrument in the distolingual. The canal appears straight, but the tooth was having buccolingual curvature. When you are inserting the first file, that is a 8 or 10 file itself, it will give an indication of that buccolingual curvature. Here also, curvature was there. You can see the distolingual root. Distolingual root, you can see the distolingual root. Here also I separated one instrument, luckily I could bypass. Radix case, you can see difference in the shadow. These are all radix cases. You can see the difference here. This was a case, the patient came with pain. You can see one missed distolingual root is there. You can see the isthmus between the distal canals. and mesially 2 roots are there. When you are seeing this X-ray, you may suspect a perforation, but this is the actual picture. This is the shifted picture. These are radix cases. The radix cases with a middle mesial canal. Here also, this is I'm treating presently this case. The patient came with pain, and there is an instrument separation here. I couldn't bypass the instrument till now, but actually the patient pain may be coming from this part. That is the distal part. Distally there is a lesion. So distally there was a missed canal. And mandibular second molars, sometimes the mesiobuccal and mesiolingual orifices may be very close to each other. So if you are getting only one orifice, you have to give a lingual curvature and search for the lingual canal from the same orifice so that you will get the mesiolingual canal. Sometimes the mandibular second molar may have 2 canal morphology, that is one distal and one mesial. But even though you are finding only 2 canals, you have to search for the additional mesiolingual canal. Here you can see the mesiobuccal and mesiolingual canals are very close to each other. It is sometimes it may originate as a deep split. This is a 2 canal mandibular second molar with 2 canals. And another one is C-shaped canal. This is a C-shaped canal. The orifices may be connected with a wide isthmus. So these type of isthmus are very difficult to instrument, but you should give much importance for cleaning and irrigation. These are some C-shaped morphologies. Just showing some more. This is a converging type. Mesiolingual and distal canals are converging together. Merging type of canals. And sometimes the mesiolingual and mesiolingual canal may be originating as a deep split from the mesiobuccal canal. Here also you can see a deep split. Here also mesiolingual canal was originating at the apical third. This is a deep split. This was the case earlier I mentioned. I missed this deep split. Sometimes the mesial and distal orifice may be very close to each other. It may appear as a single orifice, but may be very close to each other. And sometimes you may see this type of picture, like a C shape. These are all anatomical variations of mandibular second molars. Like mandibular premolars, mandibular molars also diversify. Mandibular second molar with the 2 mesial roots. These are the pictures of C-shaped canals. So you can see the isthmus level. These are the micro-CT picture. So it is very difficult to, till the apical third, sometimes the C-shape may be there. This is a C-shaped canal. You can see the mesiolingual and distal canal was connected with a C-shape. Here also you can see the C-shaped canal. This was a bit difficult anatomy here. This was also a C-shaped canal. This was also a C-shaped canal. Sometimes the C-shape will be, canals will be simple, but there may be wide isthmus. This is the isthmus. You can see the orifices, 4 orifices connected each other with isthmus. Here actually, I was only getting 2 orifices, but the mesiolingual canal was calcified, and after troughening with ultrasonic, I could find the other canal. This was a maxillary first molar with a C-shaped canal. It is also a maxillary molar C-shaped canals are a little bit rare. Then many times, this may be a cause of root canal failure. That is the isthmus connecting between the root canal orifices. You can see these type of connections. So suppose if it is a premolar, you got 2 canals. If you are not cleaning this area, you may get a root canal failure. So in such cases, your irrigation should be nicely done. You have to activate the irrigation. So these are some of the isthmuses. You can see isthmus is created. So all these isthmuses can be cleaned with irrigation only. This was also one of my case. Actually, I completed this case, and after 1 or 2 years, the patient came with headache. The patient was not having any toothache, but the patient wanted to rule out if there is any problem with the tooth. And when I examined, the tooth 6 was tender. And when I took the radiograph, I could see a lesion, a halo-shaped radiolucency in mesiobuccal root. I suspected missed the MB2 or vertical root fracture. I reopened the case and searched for the MB2 canal, but I couldn't find any MB2 canal this time also. So what I had done, I had placed Metapex. But when I placed Metapex and took a radiograph, I could see some difference here. So the Metapex flowed into the MB2 canal. How it flowed? Because of this isthmus between the MB1 and MB2 canal. A good irrigation protocol actually helps to push the Metapex into the MB2 canal through the isthmus between the MB1 and MB2 canal. But I couldn't find the MB2 canal or instrument the MB2 canal. And after some time, the patient reported after a long time, the lesion started healing. And I again started for searching MB2 canal during the operation appointment, and I could find the MB2 canal. And once it find, you can see this was the isthmus. Actually, I couldn't find the MB2 here. The Metapex flowed from here to here. So MB2 canal, sometimes if you miss, it may cause problem. Suppose if you are seeing this type of lesion, that is a decently looking operation with lesion in mesiobuccal root, you should suspect a missed MB2 canal. So this is a isthmus between the mesiobuccal MB1 and MB2 canal. You can see this is the isthmus between the MB2 canal. You can see the isthmus between the mesiobuccal and mesiolingual canal. And I am not going into the details. Sometimes you may see palatogingival groove, and you may see vertical bone loss here. So this may be cause periodontal problems, and it may cause endoperiolesion lesion or may mimic endodontic lesion. Then taurodontism, that is a deep division of the root or bull tooth. Mesotaurodontism. Then dense invaginatus is this type of invaginations may occur, or dense in dentine can occur. These also an anatomical variations. So the elusive canals entrenched within the confines of the pulp chamber challenges the expertise of even the best of endodontics. Not detecting it can lead to failure of the treatment. The pathways of the pulps are varied. The responsibility falls on the clinician to locate them so that they can be cleaned, shaped, and filled. A combination of the preoperative diagnostic tools, clinical tips, and methods can help hunt for the hidden. Thank you. Actually, my intention was not to frighten you, because root canal is a half-blind job. We all may end up with failure. It is not a 100% success job. Like other specialties, like ortho or prosto, we are not seeing many things inside the root canal. So you should be very careful. We have seen a lot of doctors doing very good prosthodontic treatment like zirconia crowns, full mouth rehabilitation with poor endodontic treatment. It is like building a very good home without a good foundation. So this is that all of you can do good endodontic treatment. But one advantage is that you can practice on extracted tooth. If you want to study extraction or implant, you should do it in patient itself or orthodontic treatment. But one advantage of endodontics is that you can collect the extracted tooth and you can practice on extracted tooth. But ignoring these things will cause problems in your practice. I realized my mistakes after seeing my own root canal failures. When I started practice, I thought just filling the root canals till the apex will help to achieve success. But now when I am seeing my old cases, I am a bit afraid. When a patient comes or a patient calls me with pain, I am a little bit afraid to take the radiograph. But you have to take post-operative radiograph. When you are started to take post-operative radiographs, you will improve your work. So you will see your mistakes. And without seeing your mistakes, you won't be able to improve. So all the best. Thank you for the patient listening. I know I am not a very good orator or a skillful orator. So, but I think you will get some idea about the complexities of the root canal. And my purpose was to just motivate you to do good endodontic treatment and also learn day by day and try to improve by day. We are all learning on every day, and endodontics is a continuously learning thing. Thank you.
The session is open for discussion. Any doubts are there, please, it's a good opportunity for you to interact with the speaker with a lot of practical experience. So I think it's a good opportunity. Sir, I have a small doubt. Like,
Thank you, sir.
because, see, from so much of variations in the root canal systems, like I myself was so much surprised about it. Because I think most of the failures or the success will depend upon your pre-operative evaluation of this root canal system. So how much the CBCTs can actually help in like identifying these root canal variations, like in a pre-operatively itself, like, and how much is it practically how much is it practical, like possible, like especially in a practical in a routine scenarios.
CBCT is very helpful, especially if it is a non-RCT treated tooth. But if there are crowns or radiopaque GP inside the canal, it will be a little bit difficult for them to identify the anatomical variations or missed canals. But it is very useful because nowadays most of the CBCTs are coming with artifact removal systems, etc. So that with a good radiological interpretation, we can identify this anatomical variation. But if it is a non-RCT treated tooth, or if there is no crowns, it will be much more easy for them to identify. So if it is a crown, if there is a crown, it is better to remove the crown and take a CBCT. What I usually do is that sometimes I will start the root canal. I will inform the patient that we will start without a CBCT first. But if I couldn't find something inside in it, I will refer the patient for CBCT. That also can be done. But one advantage of pre-operative CBC is that if there is some legal issues are coming, it will be much more helpful because you can, in the pre-operative CBCT itself, you can see that there are problems inside. But both ways you can do. But they prefer to remove the GP and crown, but it is not possible always. Yes. Yeah.
So you mentioned that in negotiating MB2 canals, if there is two portal of exit, you said that it is necessary to negotiate and clean the canals and shape it.
Yeah.
But if there is only a single portal of exit, you mentioned that if it will not cause much problem to the patient.
No, not like that, sir. Usually, if there is MB2, we have to find it. You have to try to find it that. But sometimes, if you are not getting, you can leave that. If you are not, even after your best effort, if you are not getting MB2, but you suspect that there is an MB2, you can leave that because sometimes it may be very calcified or narrow. And if it is a merging type of MB2 canal, and if you are properly operating the MB1 canal, it may not cause any problem because it may be a very calcified one or narrow one, and it may be a converging one. But if it is a separate, MB2 canal is having separate portal of exit, and if the tooth is necrotic also, the chances of failure is very high. But the problem is that studies have shown that about 95% or 92% of the maxillary first molar is having MB2 canal. But sometimes we won't be able to find MB2 canals in such a great percentage, even with best efforts. So it is like a double-edged sword. Sometimes we have to leave that MB2 canal after searching for a longer period of time, or sometimes it may jeopardize the restorability of the tooth also. So rather than roughening and searching for the MB2, sometimes you have to get into one conclusion. Should I leave that or, and before leaving that, what you can do is that take an X-ray with a distal shift. And if you're, again, if you're seeing an MB2 canal properly there, you can take a CBCT and again hunt for the MB2.
So, if
Bifurcation will be at the middle
to introduce the next speaker of the day, Professor Dr. Josie Matthew, who needs no introduction in Annoor family. He is smart, witty, charming, and diplomatic personality. Currently, he is heading the Department of Conservative Dentistry and Endodontics in Annoor Dental College. Sir completed BDS from Government Dental College, Trivandrum in 1999 and MDS from Government Dental College, Chennai in 2004. After completing his PG, he started his teaching career as a senior lecturer at Ragas Dental College. And he also worked at Sri Shankara Dental College, Workala, St. Gregorios Dental College, Kodamangalam, Pushpagiri Dental College, Tiruvalla. As an academician par excellence, he bagged the Best Faculty Presentation Award in IACD Ahmedabad Conference in 2016. He is also the executive committee member of KESOC. There are numerous national and international publications to his credit, chaired national and international conferences, and he was also the faculty for various CDE programs. He is married to Dr. GB, Associate Professor, Department of Pediatric and Preventive Dentistry, Government Dental College, Kottayam, and blessed with two kids, Ryan, who is studying in 10th standard, and Ren, who is studying in 4th standard. Wholeheartedly, I welcome Professor Dr. Josie Matthew for his session on anatomy of root canals and access cavity preparation. Sir, the stage is yours.
താങ്ക് യു ഡോക്ടർ നിധി. ഇന്ന് എന്നെ പൊക്കെ പറയാന്നുള്ളത് നിധിയുടെ വിധിയായിരുന്നു. ഓക്കെ, ഐ അക്സെപ്റ്റഡ് ദാറ്റ്. റൈറ്റ്. സോ I only selected Dr. Frenzy to talk to you on, or rather I wanted him to show you all of you his cases. Okay, why? I just wanted you to understand root canal is not that straight and innocent. Okay, it can be torturous, it can be treacherous, it can be deceptive. So don't take root canal treatment that lightly. Okay, that's why I wanted to show his few cases by Dr. Frenzy. Hope you have got an idea regarding complexities of root canal treatment, right? So I will go into just the basics of root canal anatomy as well as access cavity preparation, not much into details, because for a beginner, I think what you need is basics only. Okay, so rest of the things we will see clinically when you do your exercises on extracted teeth, or rather on in patients under faculty supervision, right? So what is root canal treatment? First of all, root canal treatment actually is what? What is root canal treatment? It's removal of pulp, cleaning and shaping, followed by obturation. Okay, so for that, if you want to, the definition say it's complete removal of pulp. So for complete removal of pulp, you should be knowing the root canal morphology or root canal anatomy. That's why we are here today. Okay, so what is root canal system? We call it root canal system rather than simply root canal because it's little complex. Okay, you have so many anatomical variations in root canal. You have accessory canals, you have lateral canals, you have isthmuses, you have pulp chamber, you have root canal, you have apical delta, so many things are there. So we call it a root canal system. So what is root canal system? It's the entire space in the dentine where the pulp is housed. Okay, it's a very simple definition by Cohen. It's entire space in dentine where the pulp is housed. So it has got two parts. As you see, there is a pulp chamber here and you have a root canal here. Okay, this and all does not need any explanation. But regarding pulp chamber, you have to see this is the roof of the pulp chamber. Okay, so this is a dentine that covers the pulp chamber occlusally in a posterior tooth or incisally in an anterior tooth. Okay, so roof of the pulp chamber. You should know what is roof of the pulp chamber because Your target in making an access cavity preparation, one is de-roofing the pulp chamber. So remember, the roof of the pulp chamber is the dentine that lies or overlies the pulp chamber. Then you have pulp horns. Okay, so these pulp horns are actually accentuations of pulp chamber into a cusp or underneath a developmental lobe. Okay, so this also is important. When you take an X-ray of a tooth with caries, okay, you may feel the caries is shallow, then why is the patient having pain? But remember, there is a pulp horn underneath the cusp. So the caries lesion, even though it's not that deep, it may be encroaching into the pulp horn. So you should know what is, you should always think of the pulp horns when you read an X-ray. Okay, so that is what is the pulp horn. Then this is the floor of the pulp chamber. What you see dark on the floor of the access cavity preparation that you do, that is the floor of the pulp chamber. This also you should understand, because you should not violate the floor of the pulp chamber. Okay, so you don't cut the floor of the pulp chamber. Why and all we will explain later. Then canal orifices. Okay, you want to remove complete pulp. For that, you have to locate the canal orifices. You can see here, you can see 3 canals here, or 3 canal orifices, or exit of the pulp root canal into the exit of the pulp chamber into the root canals. That is the orifices. Okay, so regarding the number of orifices and all, this one I will just, you can see there are only 3 orifices here, but from the previous lecture you must have got an idea where all you should look for additional canals. There can be additional canals, so look for orifices of canal. Then root canals. Root canals, I told you, it's not that straightforward. It can be having different anatomical designs. You can have a root canal that is straight like this. You can see the root apex or apical foramen opening at the root tip of the root. But here you can see the apical foramen is opening laterally. It's not at the tip of the root. Again, you can see a wide canal that narrows down at the root apex. Okay, then you can have additional curvature. Okay, it need not be a single curvature, it can be double curvatures also. Okay, so these double curvatures and all are all very tricky, because it can cause fracture of the rotary instruments that you are using. Okay, so all these things you should have an idea that root canal morphology varies from teeth to teeth, from person to person. Even contralateral tooth may not have the same anatomy. Okay, so these variations are common. So again, Dr. Frenzy was talking about apical seal. Okay, when you do root canal treatment, one objective is you should have a satisfactory apical seal. So you should have an idea about the apical third of the root canal. Okay, so what do you see here? Okay, so in periapical surgeries, we advise to resect at least 3 millimeter of root apex, or in apicectomy, we advise to resect at least 3 millimeters of root apex. Why? Why 3 millimeters? Any guess? Presence of accessory canals. Okay, there are so many accessory canals in the apical third of the root canal. So what they say is, if you resect 1 millimeter of the root apex, maybe you are removing 52% of accessory canals in the apical third. If you are removing 2 millimeter, 78% of accessory canals are removed. And if you are resecting 3 millimeters, you are resecting 98% of accessory canals. That is why we say you should resect at least 3 millimeters when you do a periapical surgery. The only thing that you should remember is root apex has got so much apical ramifications. It has got accessory canals as well as apical ramifications. Okay, then so cleaning and shaping of root apex has to be taken care with due diligence, because you have so many apical ramifications or accessory canals. Then again, one more thing that you should think is there is some concept called apical delta. Okay, apical delta means this primary canal may not be opening at the root apex. It may be terminating short of apex, but the pulp tissue will be connecting with the periodontal tissues, with the periodontium through the lateral canals or accessory canals. Okay, the main canal may be may not be ending at the root apex. Okay, it may be ending little short of apex. So anatomical variations of apical aspect of tooth has to be considered before you start your root canal treatment. That is why we have focusing so much on irrigation protocols, because your irrigant has to go into all this ramification. So understand that root apex is not that simple. Again, it has got so much apical ramification, so much accessory canals. This can make your root canal treatment little complex. Then accessory, what are accessory canals? Okay, we always hear the term accessory canals as well as lateral canals. So any minute canal that extends from the main canal in a horizontal, vertical or lateral direction, all this comes in lateral accessory canals. Okay, so any smaller canals that deviates from the main canal, it can be horizontal, it can be vertical, it can be lateral. Okay, they all come under accessory canals. And don't think accessory canals are found only in the apical third. You can have accessory canals even in the cervical third of the root canal. That is why sometimes you find accessory canals opening into the furcation area. Patient may report with furcation lesions. Okay, so you can see here 73% of accessory canals are present in the apical third. 15% middle third 11%, little more than that. In the cervical third you have around 15%. So again, you need not know the statistics, but need not try to by heart the statistics, but remember there are accessory canals as well as lateral canals in each level of the root canal. So this has also to be considered when you do your cleaning and shaping. Maximum canals, accessory canals will be present in the apical third, but it can be there. You can see cervical third has got little higher incidence than mesial, middle third of the root canal. Okay, so what is the difference between accessory canal and lateral canal? Lateral canal is also an accessory canal, but it has got an entry or exit onto the lateral aspect of the root. Okay, type of accessory. This also has got a clinical relevance, because when you see a pre-op X-ray, you may see a radiolucency on the lateral side of the tooth, not on the root apex. Very often you will say, this has got some periodontal origin. Okay, you check the periodontium, there is no pocketing, nothing is there, but still you see the lesion here. Then you think there is a fracture of the root at this level, and you don't find any evidence of fracture. Okay, think there can be a lateral canal at that level. So remember all these things before you start your root canal treatment. Okay. Then anatomy of the root apex also you have to have an idea. Okay, anatomy, the root canal tapers down. It's almost conical. It tapers down to a minor apical diameter. This area has got the least diameter or width of the root canal narrows down, not at the root apex or apical foramen. It may be little short of that. Okay, you can see it narrows down. This is called minor apical diameter. And the significance of this is, you see the cementum here overlying the dentine. Cementum is white in color. So this cemento-dentinal junction is at the minor diameter. Okay, so this actually should be your apical termination of any root canal procedure that you're doing. This minor diameter. Okay, because beyond this is considered periodontal tissues, periapical tissues. Okay, your root canal cleaning and shaping or obturation or whatever you are doing, you have no business in the periapical tissues. It should be restricted to your root canal. So you should not violate this minor diameter. Your obturation or cleaning and shaping or whatever procedure you have to maintain here. You need not enlarge that also, because you will lose your apical stop. Okay, then again from the minor diameter you can see it widens towards the apical foramen. If you take an extracted tooth and see the apical foramen, what you see will be here. This is the major apical diameter, because it's going to be wider. Okay, here. So remember the concept of the cemento-dentinal junction as well as minor diameter. So minor diameter is the part of the root canal with the smallest diameter. It should be the reference point for apical termination. It it will be 0.5 to 1.5 millimeter inside the apical foramen. Okay, just think of this minor apical diameter also when you do cleaning and shaping. Then apical foramen that corresponds to the major apical diameter as you see here. It's going to be funnel shaped. It's the opening of the canal on the exterior surface of the tooth. If you extract the tooth, what you are going to see is your major apical diameter or apical foramen. And this need not be always at the center of the root apex. So again, why is this difference? The mean distance between major and minor diameter, it's 0.5 millimeter in young individuals, it's a little more, 0.67 millimeter in aged individuals. Why? Or in adults. Why is that different? Because there is going to be cementum deposition as age advances. Your minor diameter will remain there, but there will be cementum deposition onto the external surface of the tooth. So the difference, the distance between minor and major diameter may increase with aging. Okay, but remember, your anatomic apex is the minor diameter, and your root canal treatment, everything should stop at that level. Okay, then radiographic versus anatomic apex. What is radiographic apex? What is radiographic apex? Apex of the root that you see when you take an X-ray. Okay, radiographic apex. And anatomic apex, that what is a natural apical constriction formed by the seminodental junction, that is at your minor apical diameter. Okay, this need not be. So always remember, your radiographic apex need not be your anatomic apex. Okay, that is the advantage of using your, what do you say? Apex locators nowadays. Okay, in an X-ray, you may be finding this, but your apex locators may be locating the minor constriction. So there can be some difference between your X-ray, your working length based on your X-ray versus the working length that you have decided using an apex locator. Okay, so what is the difference between these two? So there can be, on an average, this can vary even from 0.5 millimeter to 1.5 to 2 millimeter. In some cases, it's still more than that. Okay, that is why to compensate for this, when you use radiographic techniques for working length determination, you reduce by a factor of 0.5 millimeter from the working length to be on the safe side. Okay, so your radiographic apex and anatomic apex need not coincide. If you are using present day apex locators, you will be getting your anatomic apex. It can be little, it can vary from your radiographic working length. Okay, that also you please keep in your mind. Then canal isthmus. This picture was there in Dr. Francie's presentation also. You can see this is a C-shaped canal. Okay, so there is a communication between your buccal canal as well as maybe the palatal or mesial canal, palatal canal. Okay, so this narrow ribbon-shaped communication between two root canals is called canal isthmus. Okay, so the issue with canal isthmus is it's narrow and ribbon-shaped. When you use your files, you will be going into the major canals only. Your file will not go into this isthmus areas. Okay, but it harbors pulp tissue, it harbors microorganisms. If it is non-vital pulp, definitely there will be microorganisms. So you have to remove all the pulpal remnants from this isthmus areas also. So how do you do that? What can help you? What can help you to remove pulp tissue from the isthmus areas? Your files will be going into the major canals only. Your irrigant activation may be helpful. Okay, so don't solely depend on your files. Okay, there are going to be areas that are untouched by your files after doing a proper cleaning and shaping. So you have to use irrigants You have to activate the irrigant so that whatever pulp tissue is there in the isthmus area is also removed before you go for your obturation technique. And Francie was showing so many cases where he used, what do you say, ultrasonic aided compaction so that the obturating material also flows into the isthmus areas. If you are using cold Gataparka techniques, this won't flow into the isthmus areas. Okay, maybe to some extent, some of your sealer might go in. Okay, so remember, canal isthmuses are there. In canal isthmus are narrow ribbon-shaped areas that communicates between the different canals. That also will have pulp tissue. That also will have microbial colonies. That also has to be cleaned and shaped when you do root canal treatment. For that, you may have to remember to use irrigant activation techniques. Okay, then classification. Again, this picture was there in Francis' presentation. So you can see configuration of canals. There are so many different configuration of canals. Need not write down, need not try to by heart that. So this is the first configuration according to Wayne. So this is pretty easy because it has got only 4 different configurations. Okay, so you can see here there can be a single canal. There can be 2 canals from the pulp chamber that joins as one. That is 2, 1. There is 2 canals from the orifice. From the pulp chamber, it can terminate as 2 canals. That is 2-2 configuration. Again here, this is 1 canal that divides here into 2. So 1-2 configuration. So this is easy to remember. This was again, these configurations were made little more complex by Vertucci. He said there are type 8 configurations. Okay, you see here, you can see there are 2 canals here exiting from the pulp chamber. Then it becomes 1, then it again divides into 2. Okay, again, little more complex here. 2 canals from the pulp chamber that again joins here, then again divides into 2 here. So all these things, the difficulty is that, or what I want you to remember is that root canal anatomy is very complex. Okay, there is no, I don't want you to by heart all these configurations now. Maybe at PG level, somebody needs that. But remember, root canal anatomy is little difficult. You have another configuration by Gulabiwala that also is little more complex. Okay, so root canal anatomy is little complex. Then there is a classification or of root canal curvatures by Schneider. Okay, there are straight, moderate, and severe. Moderate curve, see, you can see how he has calculating this. If it is severe, the canal curvature can vary between 25 to 70 degrees. Okay, 25 to 70 degrees. Only thing is, what I need you to understand is there can be even a 70-degree or more than that curvature of the root canal. Okay, so it's going to be not that easy to manage that cases. So remember all these complexities, different configurations, different curvatures, everything is there. Okay, so my objective is of this class is to introduce root canal anatomy and how to manage that. So there are a few guidelines for access cavity preparation that was given by Krasner and Ranko. Okay, maybe Francie mentioned in between, I didn't listen completely. So you can see what he says, CEJ is the most important landmark. Okay, or is the most important landmark for determining location of pulp chamber and root canal orifices. We'll see that in the coming slides. We'll see the explanation of that. So there are 6 rules according laws of pulp chamber anatomy according to Krasner and Ranko. First, 2 laws of symmetry, 1 law of color change, and 3 laws of orifice location. Okay, we will see that. First law of symmetry. Okay, first law and second law of symmetry, this does not apply to maxillary molars. Okay, all other tooth, maybe all other tooth with multiple roots, this may be applicable. Okay, if it's a single canal, it's not applicable. So first law of symmetry, you draw a line from mesial to distal. This is a mandibular molar. what you can see here is you draw a line from mesial to distal. Okay, so the orifices of the canals will be equidistant from this line. So where it becomes applicable is you are doing a root canal treatment of a mandibular molar. Okay, you are getting two mesial canals. Okay, then you are looking for your distal canal. Okay, you get, if suppose this distal canal is in the x-axis on this line. Okay, if it is on this line, fine, there may be only one single canal. Okay, if you find your distal canal maybe 2 millimeters from this line towards the buccal or lingual, there is going to be a fourth canal on the opposite side. Okay, so that is a clinical application of law of symmetry. Okay, always mentally draw this line. Mesial, definitely you will get mesiobuccal as well as mesiolingual. Okay, then after that, if your distal canal, okay, if distal canal is towards one side of this line, mesiodistal line, there will be a second canal equidistant from the line. So you get an area where to look for the fourth canal. If it is in center, maybe it has got only single canal. Okay, so always draw this line mentally when you are trying to locate the orifices of a posterior tooth. Okay, then second law of symmetry. Second law of symmetry, again, it helps us to locate canals. What they say is, if these canals will be on the line perpendicular to the mesiodistal line. Okay, you draw a line perpendicular to the mesiodistal line, the canals will be lying on that. You can see this mesiodistal line, you can see the buccolingual line, it's perpendicular. Okay, so you get a clue where to look for the missing canal. Okay, that is a clinical implication of that. Okay, so once you start regular root canal treatment, you will get an idea where to look for canal. If you get the third canal, it's not in the buccolingual center of the tooth, definitely you will have another canal on the opposite side. You have to look for that. You mentally draw the perpendicular line, see how much buccal or lingual is the canal that you have located, go for the search for the canal in the opposite side. Okay, that is the first law and second law of symmetry according to Krasner and Ranko. Then law of color change. Okay, this also the same. I told you floor of the pulp chamber. What is the floor of the pulp chamber? In the beginning, I told you it's little more dark compared to the walls of the pulp chamber. Don't cut the floor of the pulp chamber. Just leave it like that. That is why when you do access cavity preparations and all, you will use non-end-cutting burrs. You don't cut the floor of the pulp chamber, because this color will give a clue as to where is the location of the root canals. Okay, so the law of the color change, law of color change means floor of the pulp chamber is darker compared to the walls and floor of the walls of the root canal. Then first law of orifice location. Okay, first law and second law, actually they are almost similar. You can see orifices are always located at the junction of the walls and floor. Okay, you can see here, this is the floor of the pulp chamber, this is the wall. At this junction, you find the orifices of the root canal. So if you are not getting a canal, always try to find out the junction between the wall and floor of the pulp chamber. You use your sharp probe to trough along that, so you may end up in the pulp chamber. Okay, an extension of that, orifices are located at the angles of the wall floor junction. Okay, you can see this is a wall floor junction. Again, this is the wall floor junction at these angles. That is, it will be at the corners of the access pulp chamber. Okay, so don't violate the floor of the pulp chamber. Look for color changes. Orifices are going to be at the point angles at the corners of the pulp chamber. You can use that to look for the canals. Again, the third law of orifice location, you can see some lines connecting the floor. You can see few lines along the floor of the pulp chamber. This is called dentinal map. Actually, these are developmental fusion lines. Okay, so if you locate one canal, then you trace the line that on the floor of the pulp chamber that goes from the canal that you have located. So when you trace that, you will end up in the other canals. Okay, so follow the dentinal map. That is why I said don't cut the floor of the pulp chamber. If you cut the floor of the pulp chamber, you are wiping off the dentinal map that can help you in locating the canal. So remember the laws of symmetry, remember the laws of color change, remember the laws of orifice location. This will help you in locating the canals. Okay, then Francie was talking about CEJ. Personally, I'm not a fan of CEJ because to get a proper view of the CEJ level, cemento-enamel junction level, you have to slice of the tooth. You don't do that when you do an access cavity preparation, but mentally you can draw the CEJ. Okay, so that it does not, so that you don't end up with perforating of the walls of the root canal. So here, just I'll tell you what is the law of concentricity first. Okay, external root surface anatomy reflects the internal pulp chamber anatomy. You can see at the CEJ level, this is the external root surface anatomy. Okay, you see the pulp chamber. That is also going to be a smaller version of the external root surface. Okay, you can see the pulp chamber is going to be a smaller version of the external root anatomy at the CEJ level. Okay, then another one is an extension of that, distance from the external surface of clinical crown to the wall of the pulp chamber. From here, external surface of the tooth to the wall of the pulp chamber is same throughout the circumference at the CEJ level. This distance is going to be same throughout. Okay, so again, law of centrality, this also Francie was saying, at the level of CEJ, your pulp chamber is going to be in the center of the tooth, as you see in this picture. But clinically, I don't find this that relevant, but other rules, that is your law of symmetry is very helpful, law of color change is very helpful, then laws of orifice location is very helpful when you are trying to do a root canal treatment. This one, I don't find, personally, I don't apply that much when I look for canals. Okay, so, but remember, CEJ is the most predictable as far as the design of the pulp chamber is concerned. Okay, but clinical application is limited. Then champagne bubble test. How do you do champagne bubble test? What is used? You have sodium hypochlorite as an irrigant inside in your clinic. Definitely it's there in your armamentarium when you are doing a root canal cleaning and shaping. If you don't get the canal, you fill up the pulp chamber with sodium hypochlorite. It will react with the pulp tissues, and you will find bubbles coming from that area. But I have not, if for that contact, you should have a large pulpal orifice. Okay, normally we don't get anything like that. This is there in the theory, but if the canal is calcified only, we have the difficulty in locating canal. If it is calcified, usually you don't get this kind of bubbling in that area. If not, it's there, but if it's not calcified, you can straight away see the orifice also, if you clearly examine the floor of the pulp chamber. So champagne bubble test, not that useful for from my concept. Then red line, also Francie was explaining, if it's a vital pulp, you will find a bleeding spot. Okay, that is the orifice of the root canal. Okay, then there may be this orifice of the root canal may be in a developmental groove. In that case, that blood will be maybe spreading along this groove. So if you don't get the canal, you poke that groove so that when you probe that groove, you will get a dip into the orifice of the root canal. Okay, that is red line. So if you may get a bleeding spot, then straight away you can poke that area. If you find a groove that has got a trace of blood inside that, you probe along that groove, you will get an entry into the root canal. Okay, that is red line test. Again, white line, if the Francie was talking about ultrasonic dentinal mud that covers inaccessible areas of the root canal, you can probe that area to get an idea into get an entry into the orifice of the root canal. Even without using ultrasonic tips, you get that bite line. Okay, if the root canal orifices are calcified, you find the whitish area where this dentinal mud is occluding the orifice of the canal. You find that calcific white areas, you use a sharp probe, you will be able to break through the dentinal mud and reach the canal. It need not be always with ultrasonic instrumentation. Otherwise also you can get this dentinal mud occluding the orifice of the canal. So clearly dry the pulp chamber, floor of the pulp chamber, examine that. If you find a whitish area, you use a sharp probe to open up that area. That will help you in locating canals. Then just little bit about principles of access cavity preparation. Regarding principles of access cavity preparation, there are only four. That is, one is your outline form, second one is your convenience form, third one is removal of remaining caries, dentine and toilet of the cavity. Okay, so what decides outline of your access cavity preparation? Depends on how large is the pulp chamber. First of all, in an young patient, pulp chamber may be little wide, or it may be little bulky considered compared to an older patient. Okay, so in a young patient, maybe you can have a larger access cavity preparation, because that is the first thing that decides the outline of the cavity. Then number, position and curvature of the root canals. See, there is no point in being so much conservative with tooth structure when you are doing a root canal. You have to sacrifice some tooth structure because you need to find out all the canals. Okay, you try to preserve so much of tooth structure, you make a very narrow access cavity preparation, and if you miss a canal, your patient will come back with pain. Okay, I'm not saying unnecessary sacrifice of tooth structure should be there. You have to preserve as much of tooth structure, but if your number, position and location of the root canal demands, you have to extend it so that you are able to locate the canals. Okay, very often if you don't get a canal, you may have to slightly extend the access cavity so that you get the canal. Okay, so again, this angulation of the root canal, Dr. Frenzy was talking about the radix endomolaris and all. The root canal orifice in the additional root may be little towards the lingual. Okay, that means if you suspect anything like that from the X-ray, you have to move the access cavity, extend the access cavity little towards the lingual so that you don't miss that canal. Okay, again, this radix cases, root canals may not be going vertically down. It may be going in a different angulation. It may be tilted towards the lingual. Okay, so to get a reasonable straight line access, you may have to extend the wall of the cavity. Okay, so outline form, first of all, is decided by the size of the size of the pulp chamber. Second, number, position and location of the root canals decides outline form. You can take little bit of freedom, you take little bit of liberty so that you don't miss any canal. That is the most important thing. Okay, don't miss any canal. But remember, don't remove so much of tooth structure. If you remove so much of tooth structure, what happens is your root canal treatment may be successful. After you place a crown, the tooth may get fractured. Okay, so end result also has to be kept in mind. Then convenience form. Okay, convenience form, first thing is there should be an unobstructed access to the canal orifice. Okay, so you can see here, there is an unobstructed access to the canal orifice if you make a cavity preparation like this. Otherwise, what happens if some amount of dentine is remaining here, your file, you may have to flex it so much and reach the root canal. What happens is your hand files may go, but with your rotary files, if it has got a double curvature, the chances of fracture is there. So make sure you have an unobstructed access to the canal orifice, then direct access to the apical foramen and direct access to the apical foramen or first curvature of the canal. Very often we say straight line access. Okay, straight line access to the canal. But Straight line access to what level? Straight line access to the first curvature of the root canal only is possible. If the root canal has got a normal curvature, your file will definitely curve there. Okay, so what you can do for straight line access is make your access cavity preparation, locate the canals, keep the file inside the canal, then leave your fingers, see whether the file is remaining parallel to the long axis of the tooth. If you don't have a straight line access, file will be tilted like that. Okay, so try to get a direct access to the apical foramen or first curvature of the canal. Then sometimes your access cavity preparation may be enlarged for the obturation technique that you're selecting. If you are planning to use a thermoplastic obturation, you may need a little more larger access cavity. Okay, then removal of remaining caries dentine and defective restorations. Once you make your access cavity, if there is any caries dentine remaining on the walls of the cavity, that has to be removed, because otherwise there will be microorganisms inside that. It will go into the root canal when you do cleaning and shaping of the root canal. So again, you are contaminating the root canal system. So remaining caries dentine has to be removed. Okay, any restoration that is leaky, remove that. You can, if after removal you are losing one wall of the root canal, so that saliva is seeping into the root canals, what you can do is you can build up a temporary wall with any cement. Okay, remove remaining caries dentine. Then next is toilet of the cavity. Toilet of the cavity, the term may not appear that pleasing, but still it's there in the principles of the clear of root canal treatment. This, after making your access cavity preparation, remove all the debris from the root canal. That's all. Okay, if there is any remnant of your previously existing restoration, when you make your when you open up your root canals, this, if suppose previously existing amalgam restoration was there, that may fall into the root canal. It may block the root canal. Then getting it out is going to be very difficult. So remove any such remnants of restoration that is present inside the pulp chamber. Remove any any tooth debris that is there. Remove any pulpal debris that is there from the root inside the pulp chamber. Remove that. That is what is meant by toilet of the cavity. So this also, before you enter into the root canal, you have to make sure your access cavity preparation is clean. There should be no remaining caries. There should be no defective restoration. There should be no debris, whether it's a previously existing restoration or whatever it is, should be there inside the root canal. So instruments used in access cavity preparations. Okay, you should have a round burr, 2, 4, and 6. Okay, then you should have a tapering fissure burr. It can be diamond burr or carbide burrs. You can see here, it's a non-encutting. There is blunting. There is no abrasive coating on tip of this. There is no flutes on tip of this, non-encutting. Then there's a combination of these two, endo-access burrs. You can see this is a tapering fissure burr with a rounded end. So if once you master the technique of access cavity preparation, once you're confident, you can use this endo-access burrs. Otherwise, they are little aggressive cutting. Okay, so you may cut the floor of the pulp chamber with the rounded tip. Okay, in the initial stages, I don't advise you to do that. Then endo-C burrs, these are burrs specifically designed for access cavity preparation. Again, you can see they are carbide burrs with the round, non-cutting, safe-ended tips. Okay, endo-C burrs. Then you should have beautiful explorers. Okay, you have particularly DG16 or CK17. These are long beaked, sharp probes, DG16. Okay, or you can use CK17. They are sharp probes. If there is any calcification of the orifice of the root canal from the pulp chamber, you can use this probe to poke that area. Okay, you can break that calcification. Once you break that calcification, your files may go inside. Okay, that is regarding advantage of DG16. Again, you place this long wick files into the root canal. Then you get an idea about the angulation of the root canal. how it, at what angle they are exiting from the pulp chamber. So these are very useful instruments for your root canal treatment, particularly DG16. Then you can have an endodontic spoon excavator. Endodontic spoon excavator, very sharp, small spoon excavators is there. Any pulp stones, you can use this excavator to remove any area where there is calcification in the floor of the pulp chamber. You can use this spoon excavators. You have not the big bulky ones that you use for cavity preparation. You have endodontic spoon excavators also. Okay, then even your what do you say, this shepherd's probe, this also is helpful. If there is no de-roofing of the floor of roof of the pulp chamber, you can use that hook to find out that. Okay, then ultrasonic tips. If you can invest on ultrasonic tips, that's very good. Once you start with basic endodontics, after that you can think of using ultrasonic tips, because it helps you to trough the floor of the pulp chamber to get an entry into the canals in cases of calcified access cavities, calcified root canals. Then this, what is a prerequisite before that you should always check before you take a start your burr for access cavity preparation. Should always think of have a proper X-ray. Okay, importance of multiple angle X-rays also you can see. You have just listened, that is what. What do you find in this case? Anything that you find? What is that? You have separate roots, I think. You can see there is a separation here. You can see there are two roots. So don't think, oh, this is there is a single canal here, fine, it looks fine like that, and take your burr and start doing. It's going to be very difficult. This phenomenon, what do you call this phenomenon? Sudden disappearance of canal. You can see the canal is patent till here, then suddenly it disappears. What do you call that? It's called fast break. Okay, so before you start your root canal treatment, take a proper preoperative X-ray, check for the coronal part of the root canal, follow the lamina dura. They can see here there is increase in width in this area. When you follow the lamina dura, follow the root canal, you can see it suddenly disappears here. Then you find an additional line. This may suggest a second root. There may be, the canal may be bifurcating at this level. So if you falsely tell a patient, this is very simple, I will do it in one single sitting, you may end up sitting for 4 days to complete this case. Okay, so before you start, always take a proper X-ray. Okay, pre-evaluation X-ray will help you the embarrassment of telling a patient this is something I cannot do. Okay, then again, what is innocuous, what is very innocent may also may turn to be something else. You can see there is a small radiolucency here. Okay, so this radiolucency was followed up. You can see there is a resorption, there is a very lesion associated with that area. All those things were not visible in this X-ray or not that evident. Okay, follow up. Once you see this and then you check that, you may see this. There is some radiolucency here. Okay, so don't jump into committing a root canal treatment before assessing your X-rays. Okay, so preoperative X-ray is very important. Okay, then regarding access cavity preparation. Okay, I'll just rush through the procedures. So in a maxillary anterior tooth, okay, maxillary anterior tooth, what you do is you do the access cavity preparation on the palatal aspect. Okay, so divide the lingual surface or palatal surface into, so that your access cavity should be at the exact center of the lingual surface. Okay, then don't take a burr and straight away start. You take what is shown in this picture is a round-ended tapering fissure burr. Okay, the only advantage, I don't use a round-ended tapering fissure burr. I take a round burr and start with. But for a beginner, you get an idea regarding the, you get an idea regarding the orientation of the burr if you are using a tapering fissure burr. Okay, the burr has to be held parallel to the long axis of the tooth. Okay, otherwise, if it is towards the mesial or distal, chances of perforation is there. So for a beginner, using a long-ended tapering fissure may be helpful. Once you master that, you can use a round burr and do the procedure straight away. So here you can see round and tapering fissure burr is held at right angle to the long axis of the tooth. You make an entry into the dentine, then you rotate the handpiece so that this burr is held parallel to the long axis of the tooth. Okay. So once you make the preliminary design of the access cavity preparation, you use a round burr to perforate into the pulp chamber. Okay, so the preliminary outline is made with a tapering fissure burr so that there is no chance of perforation. Okay, after that you use a round burr. Then you can use this round burr to remove the roof of the pulp chamber. Okay, then you can see here, what do you call this area? You can see here, this particular area. In an anterior tooth, you have something called a lingual shoulder. Okay, this is a slight extension of the dentine that covers the orifice of the pulp chamber. That has to be removed. Otherwise, what happens is there will be pulp tissue underneath that lingual shoulder that you won't be removing. Okay, you can use a tapering fissure burr to remove that. Okay, then you can use a round burr to again extend the access cavity preparation laterally and incisively to remove any pulp form debris. Okay, so first entry is done in the center of the tooth with a round-ended tapering fissure burr perpendicular to the long axis of tooth. Then it is straightened. Then you can use this to make the preliminary outline of the root canal. Then you use the round burr to perforate into the pulp chamber. Use that to remove any roof of the pulp chamber that is remaining. The lingual shoulder has to be removed so that, and then you refine the cavity preparation using a round burr. You get a triangular pulp chamber. It will be almost similar or to the external outline of the tooth. Okay, all access cavity preparation tend to be similar to the external outline of the tooth. Okay, so this is a young tooth. Again, in an older tooth, the root canals may be little more narrower, so it can be made little ovoid. Okay, then what all can happen in a access cavity preparation in a maxillary central incisor? Very often what happens is, I told you, you start with the burr held perpendicular to the cingulum area of the tooth. So chances of nicking of the or gouging of labial wall is there if you go so deep down. You can even go for perforation. This happens very often. Okay, so I tell anybody who start with access cavity, if you don't get a drop into the pulp chamber, take an X-ray and see where you are. Then you proceed. Okay, rather than repairing a perforation, it's going to be easy to make correction by taking an X-ray and then so that you can correct the angulation of the burr. Then again, gouging of distal wall also can happen. Okay, unnecessary gouging of the walls. Again, if you don't remove the roof of the pulp chamber, there will be pulp remnants underneath that. Ultimately, the crown will get discolored. So all this can happen. Mandibular molar, mandibular incisors, the design is almost similar. Okay, as in maxillary anteriors. Same procedure you follow. Finally, you get a triangular internal anatomy young tooth or ovoid preparation in a older patient. But again, all these things can happen. Gouging of labial wall, perforation can happen. But this is something that is little tricky when it comes to mandibular incisors. What is the incidence of two canals in a mandibular incisor? Any guess? Mandibular incisors, even though they are very narrow, very small teeth, they have got a very high incidence of additional canals, whereas it's not that common in maxillary anteriors. Okay, a mandibular incisor, some 15 to 20% of cases can have additional canal. So there is very high chance of missing of canals when you do a root canal treatment of mandibular incisors. So extend your outline and check labiolingually. You extend your outline and look for any additional canals in mandibular incisors specifically. Otherwise, you will end up with a failed root canal treatment. So this is regarding mandibular anterior teeth. Okay, maxillary premolars. Okay, so you have between the cusp tip, you draw a line, mentally draw a line. So it's you can start your access cavity preparation of the central groove between the cusp tip. Okay, extend it buccally and lingually. Okay, so that you get your buccal canal and lingual canals. Okay, you can see your palatal as well as buccal canals in the maxillary anteriors. Again, the procedure is almost similar. You use your tapering Fisher burr. Then you use your round burr to remove the roof of the pulp chamber. Okay. Once you get a drop into the pulp chamber, you can use your endodontic explorer to locate the canals. Okay. So again, the walls are refined with your tapering Fisher burrs. Ultimately, you get an ovoid preparation here. Okay. Almost same thing. So for premolars, what all errors can happen here? You can see here, sometimes for a beginner, this is something that happens. You get a small orifice here. You feel this is the orifice of the root canal. You put your file, it may go till the root apex also. But what happens is there is no complete re-roofing of the roof of the pulp chamber. Okay, this happens because you are scared because people are saying don't touch the floor of the pulp chamber, don't touch the dentinal map, all those things you are hearing. So once you get a small entry, you will push a file through that. You may reach the root apex also. But when you, after sometimes, when you do an obturation, you find there is nothing in this area because the roof of the pulp chamber was not there. The Gattaparka will go through this area, nothing else will go into the pulp chamber. Okay, so that is something that can happen. Then again, excessive preparation, overextended preparations. This is fine. You get a canal, but ultimately what happens is your tooth won't survive. It will go for fracture because what is important is remaining tooth structure. Okay, then perforation can happen because of at the mesiocervical indentation. You remember about the mesial marginal groove for a maxillary premolar. You can have a perforation here. Then your access cavity angulation may not be proper. All those things can happen. So almost a similar procedure for mandibular premolars also. But remember, mandibular premolars anatomically, they have the lingual cusp is going to be rudimentary. Okay, so that there is a lingual incline. So halfway up, you make your access cavity preparation. Mandibular premolars are very notorious because they have got too much difference in anatomy between two. That is why they are called as endodontic enigma. You can end up with failure unless you are very particular about locating all the canals. Okay, so same thing, you use a tapering Fisher burr, then round burr is used to remove the roof of the pulp chamber inside out. Okay, so almost you get a similar outline compared to maxillary premolar. Okay, then this, so there are chances of bifurcation of the canal. That is why we call it an enigma. So unless you locate that, you will end up with failure. Then access cavity preparation, maxillary molars. Okay, before you start, something that you have to be careful is you mentally decide the outline of your access cavity preparation. Mentally draw the mesial and distal boundaries. Okay, so mesial boundary for maxillary molar is the line connecting the mesial cusp tip. Okay, mesial boundary. Distal boundary is oblique ridge. Okay, you try to preserve as much of oblique ridge as possible. You definitely will have to encroach onto the oblique ridge, but don't cut through the oblique ridge because chances of tooth fracture is going to be very high if you cut through the oblique ridge. Okay, so when you make your initial preparation, What I usually do is number 4 round burr is directed to the palatal canal orifice. Why it's directed to the palatal canal orifice? Because it's the largest canal. So it's going to be easy for you to locate. Okay, once you locate that, from that you can make the extensions. Okay, so go for the largest canal. Use a large round burr or number 4 round burr directed to the palatal canal orifice or mesiobuccal canal. Then you locate all the canals. Roof of the pulp chamber has to be completely removed. You can use a round burr for that, or you can use a tapering fissure burr for that. Okay. Finally, outline form of the maxillary molars, they used to say it should be triangular. But nowadays they say it's rhomboidal. Okay, because you may have to extend it little more towards the mesial of the tooth to locate the mesiobuccal MB2 canal. Okay, incidence of MB2, there are studies that say MB2 is incidence of MB2 is varies from 60 to 90%. Even with the present day CBCT studies, they say 90% of cases have got MB2 canals. So it's there in all the cases unless you prove that there is no MB2 canal. So always you have to make it rhomboidal. Don't think of making a triangular orifice as in the olden days. Then all these things, as I told, again, overextended or underextended preparation can come. This perforation in the furcation, that also has to be, because very often your pulp chamber may be calcified. You don't get a drop into the pulp chamber. You keep on cutting, thinking I didn't get any drop into the pulp chamber. Okay, so what happens is you perforate the pulp chamber. So this has to be, that is why again repeatedly say, if you don't get a drop into the pulp chamber, okay, so what is going to helpful is you take a preoperative X-ray. You find out at what level is the pulp chamber, roof of the pulp chamber. So if it is 4 millimeters or 5 millimeters, once the burr goes in 5 millimeters, you should get a drop. Okay, if you don't get a drop, don't keep on cutting. You will end up with perforation of the floor of the pulp chamber. Okay, take an X-ray and assess where you are. Then you continue. Okay, if you have not removed the roof of the pulp chamber. So that is again similarly in mandibular molar, draw the mesial and distal boundary mentally before you start your preparation. Mesial boundary, as in the previous maxillary, it's from the mesiobuccal cusp tip to the mesiolingual cusp tip. Then distal boundary is a line connecting the buccal and lingual grooves. It's almost in the mesial 2/3 of the root canal. It's not towards the distal or towards the center. It's towards the mesial. Then orifice location, same thing. You can use your tapering fissure burr. Then you can, once you get a drop, you can use your round burr. Mandibular molar, I personally look for distal canal first, because distal canal is, if it's a single canal, it's going to be the biggest. Okay, once I locate that, then I move the access cavity towards the mesial, so that you have some reference from where to start. Okay. Okay, ultimately you get a trapezoidal design. Trapezoidal design, because nowadays we consider all mandibular molars to have 2 distal canals. Okay, so don't go for a triangular access cavity preparation. You expect to have 2 distal canals. Okay, so make it trapezoidal. Trapezoidal means you have, it's a 4-shaped quadrilateral. It's a quadrilateral with 4 walls. 2 walls are going to be parallel. Your mesial and distal walls of the access cavity preparation are going to be parallel. Okay, so that you don't miss the second distal canal. Okay, all this can happen unless you are careful. So whenever you are in a doubt, you take an X-ray and see when you do the access cavity preparation. Then only you do extensions or deepening of the floor of the pulp chamber or deepening of the access cavity preparation. Don't start, take a burr and start cutting. Don't create a perforation of the floor of the pulp chamber. So here, see, root canal access cavity preparation, cleaning and shaping, or whatever you do in the root canal treatment, there are so much details that you have to look into or consider. Okay, some of all these details will give you success in your root canal treatment. The rest, how to do access cavity preparation, you will, I hope you have got an idea what all should not be done at least. We will individually discuss when we go for your access cavity preparation on extracted tooth. Okay, if you have any doubt, you can ask then. Okay, thank you.
Thank you, sir. That was an informative session on anatomy of root canal and access cavity preparation. Moving on, we have a renowned endodontist clinician par excellence with more than 15 years of academic experience. Dr. Lisa George done her BDS from Ragas Institute of Dental Sciences and MDS from Government Dental College, Chennai. As an academician, she's a real mentor, researcher, and approved PhD guide under Kuhas University. She has several publications to her credit. She's been invited faculty for various academic forms. She has been awarded with fellowship in comprehensive cosmetic dentistry in 2016. She is an editorial member of Malanar Dental Journal and Journal of Conservative Dentistry and Endodontics, an official publication of KESOC. Being the vice principal of Annoor Dental College, often she is proudly called as Iron Lady. But on personal note, I would very much love to call her a dewdrop who, as a person, is always feels to be a perfect getaway when some hustles get you down. Ma'am, much love and happiness to have you here, and looking forward to hear from you on cleaning and shaping of root canals. Welcome, ma'am.
Check. Thank you, Dr. Jis, for the introduction. And hope you're all not tired. Yeah. This is a very short lecture. It is more a practical way of doing root canal using rotary endodontics. So this is the last lecture of today. Okay. So my contents will be on the cleaning and shaping of root canals. We will discuss on different methods of doing cleaning and shaping, the sequence of using the rotary files, the importance of irrigation, as Dr. Frenzy and Dr. Josie has been mentioning it. Irrigation plays a very important role nowadays, and what all precautions should we take when we use rotary endodontics. So cleaning is removing the organic remnants from the root canal. So this is done with the help of irrigants, and shaping is done to receive the three-dimensional obturation material into the root canal space. And this is done by our instrumentation technique, right? But ultimately, both go hand in hand. Unless you shape your canal properly, or irrigant material is not going to reach the periapical area. So both goes hand in hand. You shape the canal, clean the canal, and it goes on like this. So shaping can be done by manual means. You have rotary files to do it, and you have reciprocation systems. These are the basic three ways you can do shaping of the root canal. Manual is by using reamers, K files, and H files. Many of you would have already done root canal treatment, but the problem with these manual files are it is time consuming, right? Yes, it takes lots of time and practically very difficult to do a single visit endodontic treatment with manual instrumentation. And also The stainless steel files, which we use in these files and reamers, they are not flexible. Till size 20, it is fine. Beyond that, once you go to 25 size file, it is more stiffer. So in curved canals, there are more chances for ledging and transportation. But keep it in mind, you cannot neglect our hand files. The hand files play a very important role in canal location and during the initial phase of instrumentation. You have to enlarge the canal to a sufficient size before you put your rotary files into the root canal. So never leave hand files. It is still there. It is still happening. Rotary system, from the picture also, the file is going to rotate inside the root canal. It is in a circumferential manner. So the shaping will take place in a circumferential manner. You have umpteen number of systems nowadays. And some are there, some are not there. The newer systems which we use nowadays, the Pro Taper Gold, which is there in your kit, they are heat-treated files. The advantage of using these heat-treated files are they are more flexible. Yes, so you can easily, it can easily go through the curved canals, and they are more resistant to fracture. You can use for more number of canals, but be careful. I will not always say that. It depends on what type of canal it is. If it is a straight canal, fine. If it is a curved canal, you have to limit the number of uses. So heat-treated files are more flexible and more cyclic fatigue resistance. You still have another system called as reciprocation system. Have you come across the system, reciprocation? Anybody knows about this? No. So reciprocation system, so this here the files move in a clockwise, anti-clockwise direction. Some systems, the clockwise rotation will be more, less of anti-clockwise rotation, right? So instead of going in a circumferential manner, the file will go in a clockwise, anti-clockwise manner, right? The whole purpose of introducing this reciprocation system was to maintain the canal anatomy. Is the canal always round? No, you saw so many pictures, right? Dr. Francis showed all the canals. They are not round exactly. It will be sometimes oval, but you don't want to make an oval canal round, right? We would want the canal to be maintained its anatomy, right? So when you use, the manufacturers claim that if you use a reciprocation system, you can maintain the canal anatomy, and these reciprocation system cause less apical debris extrusion, right? When you do cleaning and shaping, what happens? You're cutting the dentine. So there are debris. So this debris, when it is pushed apically, it can cause post-endodontic pain, which will be a lecture tomorrow by Dr. Sinju. So that was the whole reason of introducing this reciprocation system. But unfortunately, this system is not that popular. Probably because of the cost, and there are multiple other reasons. But more commonly, clinicians go in for rotary files, and the demo on the class your hands-on will be on rotary files. So now we will go on to the shaping part. So having located the canal orifices like this, now your next step is going to be enlargement, right? The first step in shaping of the canal is doing the initial patency. Initial patency is passive exploration phase of the canal using small files. You have to first locate the canal orifice with a smallest size file. The most common preferred size is number 10 file, right? You can gently put a number 10 file into the orifice and see whether the orifice is there or not. And now you have C+ files. Other than the K files, this is C+ files. The advantage of the C+ files are they are little modification of your K file. They are more stiffer, and you can easily penetrate through calcified canals. Okay, so the Dentsply has come up with C+ files. So why do we do this initial patency? It is done to appreciate the morphology of the canal orifice, to check for the patency of the canal orifice, and to check the resistance of the file. Sometimes the file may go coolly till the apical terminus. Sometimes it may not go, right? It will go halfway through and stop there, right? So once after you have realized that there is some sort of resistance for the file to enter, never push a file inside the root canal. That means there is some sort of obstruction. So that is what we would be doing in the next step called as early coronal flaring. If you look into this picture, you can see a small dentine shelf here, right? That is a sort of coronal obstruction for the file to reach the apical area. So it becomes mandatory to remove that obstruction in the orifice. And so why do we do this early coronal flaring? To reduce the contact between the file and the dentinal walls so that you get a straight line access into the middle and the apical third of the canal. So after doing the initial patency, if you find a resistance in the file, don't push the file beyond that. Do an early coronal flaring. So this early coronal flaring is done with the help of an SX file, which is there in your kit, the Pro Taper Gold, which has been given to you. If you don't have an SX file, you can use a Gates Glidden drills, 1, 2, or 3. Probably for a molar, 1 or 2 Gates Glidden drill will do. So why do we go in for early coronal flaring? You get better tactile sensation at the apical constriction. I told you, initially the file may not go up to the apical constrictions. Once you do the early coronal flaring, you will find that this obstruction will go, and most of the cases, majority of the cases, you can take your file till your apical terminus. So you will get better accuracy in the working length determination, and there is again less chances for apical debris extrusion. So what all did we do after locating the canal orifice? We did check for the initial patency. If it is not fine, if there is a resistance, we proceed with early coronal flaring. Then we will go to the next important step called as a glide path. What is glide? Have you come across the term glide? Aeroplane landing. The same thing holds good here. So it is glide path means when you put a file inside the canal, it should go coolly from the coronal orifice to the apical constriction. There should not be any obstruction. That means your file, your number 10 size file, should be super loose inside the canal. This is very, very important before you put your rotary file inside the canal. You have to do this particular step called as glide path. That means the file, when you put from the coronal orifice, it should slide through the coronal, middle third, and the apical third to reach the apical terminus. And your number 10 size file should be super loose inside the canal. So this is how it should be, right? It should go coolly into the apical constriction. So why do we do glide path? To reduce the chance of canal transportation. You want the position of the apical foramen in the same position itself. You know, if it is on the distal aspect, you want it only at the distal aspect. You don't want to take the foramen to the mesial aspect. Less apical debris, extrusion, and canal centering ability. If it is a curved canal, you have to maintain the curvature of the canal. Right? That's what we call it as canal centering ability. So this is just a schematic picture to show how a pulp canal wall will look like when you take a glide path. So this is the initial pulp space canal outline. See how you put a number 8 file first, then you put a number 10 file, then you put your number 15 file. See how the pulp canal anatomy is. Is there a difference? After you have taken a glide path in that root canal, you have made the canal pathway smooth. You have now prepared the canal for rotary files. So what I would like to convey here is hand filing is very, very important before you put your rotary files. Nothing to replace hand filing. The system which we are going to use is ProTaper Gold. The ProTaper Gold, you have SX, S1, S2. S1 and S2 are shaper files. S stands for shaper files. Who all have used ProTaper? Any four of ProTaper you have used? No. None of you, fine. So S stands for shaper files. F1, F2, F3, they are finishing files. Metallurgy, as I told you, this is a heat-treated file, so it has got better flexibility. And keep it in mind, the gold doesn't stand, the holds good for the color. It is not because of the color. This is because of the coating of titanium oxide on the file. When you do heating and cooling of the file during the heat treatment process, there is a coating of titanium oxide on the file. Based on the thickness of the titanium oxide, you call it as either gold or blue. Reciproc file comes as reciproc blue. ProTaper is ProTaper Gold. The speed, all the systems come with a standard speed. And this speed can be adjusted in the endomotor onto which you are going to attach the file. And there is a torque for each file. SX S1 all torque alla S2 right? F1, F2, F3 will have another torque. So all these values can be set on the endomotor before you start working with your rotary file. So what are the files we use here? You have SX, S1 and S2, F1, F2 and F3. S1 and S2 are the shaper files. SX is for orifice enlargement, I told you. And F1, F2 are the finishing files. And another important aspect of this ProTaper file is it has got variable taper. The normal file reamer, what you use for hand filing, they have standard taper. That means if it is a 2% tapered instrument, the diameter is going to increase 0.02 mm every mm, right? Whereas in case of variable taper, it is not the case. See, in the tip, the diameter is 0.19. D6, it is 0.5. It varies. That's because each file has got its own role in shaping. SX is for orifice enlargement. S1 and S2 is for shaper. They are going to shape the coronal and the middle portion of the root canal. Right? F1, F2, F3, they are going to do the finishing part. They are going to work on the apical third of the root canal. Am I clear how the system is going to work? SX is for orifice enlargement. F1 and F2, they're going to work on the coronal and the middle portion of the root canal. S1, S2, F1, F2, F3, they're going to work on the apical third of the root canal, right? Moving on to the tip diameter. The SX has got a tip diameter of 0.19. S1 has got a tip diameter of 0.18 mm. S2 has got a tip diameter of 0.20 mm. F1, F2, F3, it is in the color code of yellow, red, and blue, right? You are going to finish your rotary filing procedure either with F1 or F2 or F3, depending on the size of the canal. So the technique which we follow in all rotary instrumentation is crown down technique. Crown down means corona apical technique. We are going to shape the coronal third with the shaper files and finish the apical third with the finishing files. And let's see the sequential step to do the ProTaper filing. First, you're going to enlarge the canal in the sequential order of 10, 15. We want 10 and 15 should be to be super loose inside the canal. Number 20 K file can be snugly fitting inside the canal, right? You can make sure it just goes into the root canal. At least it is snugly fitting. Once after you have done this glide path, then we will go on to the ProTaper files. S1, S2, shaper files is going to work on which portion of the root canal? Coronal and the middle third. Then F1 ProTaper rotary files. In case of larger canals, we have to go on to F2 and F3. Hope I am clear with the theoretical aspect of using ProTaper Gold. And when you put these files on the order of S1 and S2, very important is you have to check for the patency of the root canal. So in the apical third, sometimes the dentinal mud can get accumulated, right? So what happens if a dentinal mud gets accumulated? You're going to lose your working length. Instead of 20 mm, it is going to be 18 mm. You put all the filing. Ultimately, when you put your GP, it is going to be 3 to 4 mm short of the apex. So the pushing of the apical debris at the apical third is one of the main reason for your working length being short when you take your master course. So in between your filing procedure, when you put your S1 and then go back to S2, take a small size file. Make sure your file is going up to the working length. Then go to S2. After doing S2, do a patency filing again with number 10 size file, irrigate it nicely, and then go to F1. Okay, patency filing is very, very important when you're changing your files from smaller to larger size. So this is a short video by Clifford Riddle. He showed it has been done on a mesiolingual canal of mandibular molar. It shows how you can proceed with a pro-taper rotary files. Just have a look at it.
We will be using to demonstrate the pro-taper gold technique. Upon completion of the initial access, a canal lubricant with a viscous chelating agent is introduced to aid in exploring the
pro-taper files.
introduced. In this case, a number 10 is placed in the mesiolingual canal. This is the only canal we will focus on in this video. The hand file has been pre-curved and is gently worked to our estimated length.
The canal, no pressure.
Hypochlorite. Creating a good radicular access is the purpose of the SX instrument. This is worked into the canal space. The focus is on the coronal aspect. As you can see, we are employing a brushing technique, always working away from the furcation. Upon removal, the debris pattern in the flutes clearly shows that the instrument was only working in a very small area of the canal. Here you can see how the SX flared the access to this canal. After more irrigation, the glide path must be established. In this case, we utilize the Pro Glider instrument. This is carefully taken to length.
This is a rotary Pro Glider. Instead of a file, you have rotary files to take a glide path.
Up, and we are able to brush our way to length.
See, if you can look into this file, you can see that the debris are more on the coronal portion of the file, not at the apical third. That means the file is working on the coronal portion of the root canal. But when you put your file, you have to take it till the working length.
The canal space. We take a few extra strokes here, just so you can see it clearly. With length achieved, let's look at the debris pattern. What little debris is generated is concentrated in the middle of the file's flutes. The hand file, gently worked into the space here, shows us that we are still on target with our working length. This
till the working length before you put your F1.
This instrument is a 20 at the tip, so it's going to be very close to the apex with its initial insertion. And because of the decreasing taper design, this instrument is not going to do much work beyond the apical zone. We work the instrument in the space very gently until we are satisfied that we will not progress any further, or we've reached length. Our finishing criteria is based upon the debris pattern in the flutes. As you can see, there is very...
Okay. So we'll stop with the video. So F1 is if the canals are smaller. If you feel the canals are larger, you have to go to larger size like F2 and F3. So as you saw in the video, you have to use a lubricant, which is going to help you in efficiency of the file. And when you put your file inside the root canal, always remember that there is going to be debris between the flutes, right? So these debris have to be removed with a wet cotton. Otherwise, the efficiency of the file is lost. So put S1 to the length and then take it out, remove the debris completely from the file and then go to the next canal. Don't put the same file again into the next canal. You're going to carry the debris from this canal to the next canal. Wipe the file nicely with wet cotton. So big quick recap of how to put a rotary file. The first is checking the initial patency, then do the early coronal flaring with an SX file, then take a glide path. And in the initial stages, I prefer you to do a glide path till 15 size and 20 to be snugly fitted inside the root canal. Then go to rotary files, S1 and S2, F1, F2, F3. In between, you have to check for apical patency. Right? So with this, we are coming to the end of the instrumentation part. As I told you, irrigation comes along with shaping. When you're doing shaping, you have to use sodium hypochlorite lavishly. The normal irrigation protocol which we follow is 2.5% or 5.25% sodium hypochlorite to remove the organic debris from the root canal because it has got tissue dissolving property, and a final rinse of 17% EDTA for 1 minute, which is a chelating agent. The use of EDTA is to remove the smear layer from the root canal. As you all know, when you cut any tooth structure, there is going to be smear layer. Only if you remove the smear layer, the dentinal tubules get opened up, then you give space for the sealer to penetrate laterally. So use of sodium hypochlorite and EDTA is mandatory for all cases. Chlorhexidine gluconate is indicated only in case of non-vital teeth. When you find it is a weeping canal or a case with large lesion, we can go in for sodium hypochlorite. And a word about irrigant interactions. The sodium hypochlorite can interact with chlorhexidine and give a product called as parachloraniline, which is a toxic product. Similarly, this EDTA can club with chlorhexidine and give a white precipitate, which is again going to block the dentinal tubules. So why I told you all this is, when you're switching over from one irrigant to another irrigant, wash the canal nicely with saline and then go to the next irrigant, right? Again, sodium hypochlorite and EDTA, when you're using together, this EDTA will have good chelating capacity, but unfortunately, it will affect the tissue dissolving property of sodium hypochlorite, right? Am I clear? So when you use EDTA and sodium hypochlorite, again, this EDTA can affect the tissue dissolving property of sodium hypochlorite. So after using sodium hypochlorite, when you give a final rinse of EDTA, before you give a final rinse of EDTA, wash the canal nicely with saline, remove all the sodium hypochlorite, put EDTA inside the root canal and then activate it. Right? So irrigant interaction should be always kept in your mind. When you switch over from one irrigant to another irrigant, wash it with saline and then go to the next irrigant. A word about syringes. The syringes, you can use any of these syringes, 2 ml, 2.5 ml, 5 ml, 10 ml, whichever according to your convenience. And what is preferred are Luer lock syringes because they have threads onto which you can attach your needles. Luer lock syringes. And needles are of different types. We have open-ended needles and closed-ended needles. Right? The first three are open-ended needles. Some are beveled, it can be notched. And the closed-ended needles are side-vented needles. If you see this, the tip is closed in all the last three needles, but you have vent in the side. This is a single side-vented needle. This is a double side-vented needle. These are multiple side-vented needles. Multiple side-vented needles are not available very commonly. You get this side-vented and double side-vented needles online stores. So why do we have to switch on from open-ended needles to closed-ended needles? That's the question. See, now the recent concept is when you do irrigation, the irrigant has to reach the periapical area. So if you use an open-ended needle and take it up to the working length, this irrigant can go into the periapical area, especially the sodium hypochlorite, and can cause damage to the periapical tissues. Whereas if you use a closed-end needle, you have the liberty to take the closed-end needle at least very close to the working length. So that is one reason now we have switched over from open-ended needles to closed-ended needles. So in a closed-ended needle, you can take the needle as close to the working length as possible. What the textbook say is you can make it 1 mm short of the working length and then proceed with the irrigation. Because as you all saw in the previous lectures, the apical area is the most critical area. You have your lateral canals, you have accessory canals there. So the irrigation has to be effective in the apical area. Right? So closed-ended needles are what recommended nowadays. And when you look into the thickness of the needles, it can be a 30 gauge needle, 27 or 23 gauge needle. But what is most preferred is the 30 gauge needle. Size number കൂടുന്തോറും thickness കുറയാണ് അറിയാലോ അല്ലേ. So a 30 gauge needle is what is preferred, a 30 gauge side vented needle. When you use a 30 gauge side vented needle, the irrigant can flow in and around the periapical area and clean the apical critical zone of the root canal. So if you don't enlarge the canal, your 30 gauge needle is not going up to the apical area. So this is the first, this picture shows that you have used a 30 gauge needle, but it has not gone up to the working length. So you have to enlarge the canal sufficiently to make sure that your 30 gauge needle goes up to the working length. So sufficient enlargement, use of 30 gauge needle with side vented needles till the working length is what is recommended for irrigation. We will give you a side vented needle during the demonstration. You can try using it. And a word about root canal anastomosis. I'm not going into detail because from morning you would have seen lots of images from Frenzy. Root canal is not proper round, right? You have lots of isthmuses, cul-de-sacs and lateral canals. It is not possible for the rotary file to clean those areas. What you can maximum do is irrigation. So for that, you have to just using a needle syringe irrigation, your irrigant is not going into the isthmuses and cul-de-sac area. You have to activate the irrigants. If you activate the irrigants, some pressure will be there. It will penetrate these cul-de-sacs and clean the tissue from the critical areas. So how do you do irrigant activation? The most easiest way of doing, we don't require any great equipment for that. It is the manual dynamic activation method. In manual dynamic activation method, you take a master cone. You would have selected a master cone after doing your cleaning and shaping. Suppose if it is a 40 size master cone, you flood the root canal with sodium hypochlorite or EDTA, whichever irrigant you want to activate. Put the master cone and give up and down movements for the gutta perca so that this irrigant can be pushed into the lateral canals. So that has to be done really fast. You have to do it really fast. Take a master cone, push up and down nicely so that it can reach the critical areas in the root canal. So manual dynamic activation does not require any equipments. Then you have ultrasonics. I'm not going into detail of ultrasonic. The ultrasonic tips are available, which can be placed inside the root canal and activated. In ultrasonics, you have cavitation, acoustic streaming, eddy current. Okay, all those are going to act on the root canal walls and remove the smear layer too. And you have endo activator. This works on a principle of sonic. So when you do needle syringe irrigation, it is mandatory to activate the irrigation. Only then you will be able to clean the critical areas in the apical zone. So a word about intracanal medicaments. Intracanal medicaments is not always needed. Only when you find a lesion and you have it, if it is a non-vital teeth or if it is a weeping canal, you have to use a medicament. The most commonly used medicament is calcium hydroxide. We can also go in for antibiotic paste. The calcium hydroxide, when it is used in saline or in a viscous agent, when you mix freshly, it is more effective. than the ready-made calcium hydroxide which you get in the tube. Calcium hydroxide mixed with saline or glycerin, you can mix, place it inside the canal. For a period of 2 weeks, you can place it inside the canal. And again, after 2 weeks, if you want to repeat it, clean the canals nicely and then put a different pack of calcium hydroxide. If you want it for a longer period of time, you can go in for Metapex and iodoform paste. All right. So a word of caution when you use nickel titanium files do fracture. The manufacturer always say use once through, but in an Indian scenario, is it possible? Do we waste anything? Even the used files I don't throw off. I just keep it by my side. Right. So fracture rate, see maximum, I'll just tell you, if you use a Pro Taper Gold, you can use it for 5 or 6 canals. That's what they recommend, not more than that. If it is a curved canal, maximum 2 canals. After that, you have to discard the file, right? So it all depends on the complexity of the root canal. If it is a straightforward case, more number of canals. If it is a curved canal, limit the usage of the file. Difficulty in reaching the apical area, and it sometimes does not debride the whole canal surface area. So this is a picture to show you that, see, if an oval canal is there, when you use a rotary file, what is happening? There are uninstrumented areas on either side, right? So this is one problem which we face with rotary instruments. In such cases, they say reciprocation is good, hand filing and irrigation is mandatory. Only then you can clean those uninstrumented areas. So don't always rely on rotary. Club, hand, then rotary, and irrigation. All those is going to help you in the success of the endodontic treatment. So the thumb rule for rotary filers: use gentle pressure, okay? In and out motion in short amplitude. Pressure file, short amplitude of 1 to 3 mm. In between, take the file out completely. See how your file is. Wash it off, clean it off with cotton, remove all the debris, and then put it back again. Continuously canal the file idalla. Right? So gentle pressure is recommended when you're using nickel titanium files. Less pressure, torque, and time required, more likely the file failure can be prevented. So take home message for me is hand, rotary. Unless you have taken a glide path, don't go in for rotary. So when you're using rotary files, irrigation is mandatory. When you're doing irrigation with syringe and needles, activation is important. Only then you will be able to clean the periapical area, right? Thank you so much. You want to ask anything now? Shall we have the discussion during the hands-on session? Yes? Thank you.
Thank you, ma'am. We have come to the end of the lecture sessions. Moving on to the hands-on session, requesting all those who are included in batch A, kindly proceed to lecture hall 4 for hands-on. Those who are in batch A. And students in batch B, kindly move to the respective department. A gentle reminder to assemble tomorrow at sharp 9 a.m. for the lecture. Once again, appreciating your presence. Thank you. Have a happy learning.